Yes.
Recording in progress.
Good evening to all the delegates who have joined from all over the country. A very warm welcome to all of you to this fourth episode of the Feto Vision webinar series. Today we have an eminent speaker lineup along with excellent panelists and moderators for a genetics webinar. And I first of all take the pleasure to invite the convener of Feto Vision webinars, Dr. Bhaskar Pal. Himanshu, can we have the slide? Sir is a senior consultant at Apollo Kolkata, and he was the past president of IAG and past president of BOGS. We all know, sir, and I request sir to address this fourth webinar episode of Feto Vision.
Good evening. Thank you, Prasanna. Good evening, everyone, and warm welcome to the fourth episode of the Feto Vision webinar series. I keep saying the same things every time that COVID has left many scars, but the only good thing it has left us is the exploration of the virtual medium. And as much as we enjoy face-to-face conferences, I think for education, the virtual medium is going to be going forward the most valuable medium for learning, and because it is more accessible, more equitable. It is my pleasure to thank my team, Dr. Sita Ramamurthy, Dr. Aparna Sharma, Dr. Niharika Malhotra, Dr. Prasanna Roy, and Dr. Shama Devdasan. And I also take this opportunity to thank Conference International and MFINE for their support. And our aim is to do focus webinars on different specialities. And as you know that we run one on infertility and reproductive endocrine, one on endoscopy, one on fetal medicine, and one on general obs and gynae. And we try to keep the topics which are clinically important, and that's why today is on genetics and fetal interventions. And I thank Dr. Suresh, Dr. Geeta Kollar, and Dr. Anita Kaul, who've taken their time out to speak today, and Dr. Pragya Mishra and Dr. Sangeeta Gupta, who chair the talks. And we have a panel on appropriate use of genetic tests, which is very essential for us gynecologists who do not do fetal medicine as a specialty. And we have Dr. Sita Ramamurthy and Dr. Veronica Aurora moderating the panel. And I thank them and the panelists, Dr. Jeena Deka, Dr. Jyotsna Gupta, Dr. Manisha Babe, Dr. Shashwati Mukhopadhyay, Dr. Vandana Chadha, and Dr. Vinayak Das. Thank you very much, and I hope we have a fruitful learning this evening. Back to you, Prasanna.
Thank you, sir. Thank you for your time and your address. Now we move on with our program scheduled as such. First of all, I invite our respected chairpersons, and we have two chairpersons for this evening. First of all, I invite Dr. Sangeeta Gupta ma'am and ma'am is the director and the professor of Obs-Gynae at Maulana Azad Medical College, Delhi, and in charge of fetal medicine at Lok Naik Hospital, New Delhi. Welcome, ma'am, to this fourth episode of webinar series of Feto Vision.
Good evening, everybody.
I request you, ma'am, to invite our first speaker for the evening, that is Professor S. Suresh. Sir has to catch a train. That is why we shifted Sir's talk from the third to the first. And I request you to invite him. Our second chairperson for tonight is Dr. Pragya Mishra Chaudhary, and she's a consultant infertility specialist at New Life Test Tube Baby Center at Patna. Welcome, ma'am, to the fourth episode of Feto Vision webinar series. I request Dr. Sangeeta Gupta ma'am to invite Professor Suresh.
Good evening.
Can we have the slide, please, Himanshu?
Good evening, everybody. I thank Dr. Bhaskar and Dr. Sita to invite me on this webinar on such an important issue. And it is my proud privilege and honor to invite Dr. Suresh for this talk. Sir actually needs no introduction. And I can only put in one line for him from my heart. that he's the father of fetal medicine for India. And the way which sir has shown to everybody is unprecedented. And I know that he is still ready to hold anybody's hand who wants to do good work. And with that, I just request, sir, that we should not waste the precious moments of the knowledge which he is going to impart to us. Sir, please.
Thank you. Can I share my slide?
Yes, sir.
I hope you're able to see my slide.
Yes, sir.
Okay. Good evening, and thank you for inviting me to this webinar. Today, I'm going to give you a very broad overview of fetal therapy and what are the possibilities, what are the possible situations we can do fetal therapeutic procedures. So, first of all, we do fetal therapy for conditions that will progressively worsen in utero, and there's increased morbidity and mortality if left untreated. So we can do either prenatal correction, we do procedures to alleviate further damage, and also to optimize survival. So most procedures are temporary and what we call as palliative in utero. Some aim at the root cause, and that, for example, laser for TTTS is we are aiming to block the condition which and preterm birth in most cases. Now, one of the most important things about fetal therapy is whichever fetus you are treating in utero, it would need some kind of neonatal treatment and care. Neonatal treatment prior to discharge will be required only for residual disease. Long-term care is given as appropriate. And there are also some condition-specific treatment definitely required after discharge. For example, if this patient has had a post-urethral valves, then it's a condition-specific treatment which you need to do. And also short-term and long-term follow-up is required for these babies. Now, if you look at conditions which are amenable for fetal therapy, where we have anemia on top of the list, then we have chorioangiomas, hydrothorax, CPAMs, bronchopulmonary sequestration, and lower urinary tract obstruction as some of the conditions. In twins, of course, we have twin-twin transfusion, selective fetal growth restriction, trap sequence, TAPS, and discord for anomaly. Almost all of them, the issue is in monochorionic twins. And there are other conditions like neck masses, tachyarrhythmias, critical aortic stenosis. So I'll just give you a few of them. But before we proceed further, we have to understand that there are huge challenges here, decision-making challenges to do or not to do, technical challenges which gives us in actually doing the procedure. And there are other challenges like patient logistics, cost of neonatal care, ethical issues, and also coping with failure of the procedure. Because the family spends a lot of money going through a procedure, and you have done the procedure well, but still the pregnancy may be lost, and we have to be very careful about it. So pre-procedure counseling is very important. If you look at decision challenges, many times we have a dilemma whether to do or not to do. Now, when I say do or not to do, I mean, here's the case of lower urinary tract obstruction, and there's good amount of liquor. So should I go and do a shunting? Should I not go and do a shunting? Is it going to benefit or no? And similarly, the time at which you decide to do an intrauterine transfusion, even a laser. The question is who decides? And also, there is lack of awareness of natural history. So here's the monochorionic twin, which I've been following up for weekly. And then I tell the patient, I reassure her, see, you're already come to around 24 weeks. Things are going well, so you should be happy about it. The next week, she comes with a full-blown twin-twin transfusion syndrome. So this is very, very much possible. Then if you look at technical challenges, we have access to the fetus and also the type of the procedure. You may have the same condition, and we may have several procedures which are possible to do. For example, when there's a monochorionic twin with one discordant for anomaly, You could do a bipolar cord occlusion, or you could do a radio frequency ablation. So which one is the right thing to do? Also, we need to consider. And of course, that depends on infrastructure availability. Now, let's go and look at some conditions where we do medical therapy for fetal goiter, for therapy for tachyarrhythmias, and also therapy for bradyarrhythmias. So if you consider fetal goiter or fetal hypothyroidism, the most common reason why the thyroid enlarges in utero is hypothyroidism. Of course, it can also enlarge in hyperthyroidism. So whenever there's a neck mass, and there's a smooth enlargement you can see in front of the neck, we do amniotic fluid TSH, and can also do fetal blood TSH by doing a fetal blood sampling. And once we see TSH is high, then we can install intraamniotic thyroxine. So we don't need to do intravascular, we should not do intravascular thyroxine, but we put it in the amniotic fluid. So this thyroxine gets diluted and the baby slowly swallows it over a period of time. It's like having the tablet thyroxine every day for the baby. Weekly doses may be required. We need to look at also the case selection, because all goiters don't need treatment. In some cases, when the goiter is very large, then fetal MRI may be required to look for tracheal compression, and if the baby is born, to need for the exit procedure. One important thing to say is, by giving thyroxine, the goiter will not disappear in utero. It may become a little less in size, less in vascularity, but it will not disappear, and it takes only after birth it can reduce. Then we look at tachyarrhythmias. When the fetal heart rate is more than 250 with a 1:1 rhythm, we call it as supraventricular tachycardia. And here we look for signs of fetal cardiac failure, the fetus. And of course, this needs immediate treatment. And the immediate treatment options we have is to hospitalize the patient. We do maternal bloods. Then we can give maternal digoxin, and also maternal, we can give flecainide to the mother, 100 milligrams oral 3 times a day. Also, the other options we have are sotalol and amiodarone, which are less used, and we monitor the rhythm weekly. It will take a few days for the rhythm to come back, because adequate amounts of the drug has to build up into the fetal vascular system. But the important thing of reason for hospitalization is not for the fetus, but actually for the mother, because you're giving, and the mother's cardiac rate, everything is normal, but we are still giving her an antiarrhythmic drug. So we do cardiac review 2 weekly, and then the pregnancy is followed up. Remember, the thing can reappear during the pregnancy, or maybe completely stable during the pregnancy and can reappear after birth. There are other minimally invasive fetal procedures like amniodrainage, intrauterine transfusion, vascular occlusions and dilatation, and also selective feticide, like for higher order gestation, fetoscopic laser and radiofrequency ablation are all conditions that are there. So let's look at where we do amniodrainage. When there is unexplained severe polyhydramnios, purely for maternal discomfort. Also, when there's stage 1 TTTS with severe hydramnios after 26 weeks, and serial amniodrainage may be required in some cases. Of course, there's the risk of PROM. We use an 18-gauge needle, local anesthesia, and we do rapid suction, can remove up to about 4 liters, which can be removed safely. We remove fluid till that single deepest pool is less than 8 centimeters. Then the question of fetal anemia, which is proven to be probably the best form of fetal therapy. We do it for RH isomerization as the most common indication. Also have parvovirus, alpha thalassemia, infections, and also fetal-metal hemorrhage. Of course, infections, we use it for parvovirus. Now, when there's RH isomerization, ICT is positive, greater than 1 in 16 titers, or it could also be a non-immune anemia. So we classify that we identify anemia by doing MCA PSV more than 1.5 mom. And when the situation gets worse, you can also see hepatosplenomegaly and ascites. So the choice of intrauterine transfusion is where to give the transfusion. There are several sites you can give the transfusion, that in the base of the umbilical cord. Our preferred site is the intrahepatic portal vein. And some people use the free loop of the cord, but we would not recommend using free loop of the cord. So we use O negative leukodepleted washed packed cells irradiated with a high hematocrit of 75 to 80. Repeat transfusion may be required. We usually plan the last transfusion between 34 to 35 weeks if delivered near term, and then neonatal care can be given. Remember, with the first transfusion, before you give the first transfusion, you need to identify take blood samples for identifying the baby's blood group and RH type. Of course, the most gratifying thing is the success rates are very huge, to almost like 95-97%. Then we look at fetal shunting. We do thoracoamniotic shunt for pleural effusions or large macrocystic CPAMs, or for lower urinary tract obstruction. So here are a few pictures of pleural effusion. You have bilateral effusion with some edema, unilateral effusion with no skin edema, or bilateral one having larger effusion, one having a smaller effusion. The question is which of these indications are indicated for treatment. Now, pleural effusions, we have small to moderate effusions. You can have unilateral effusions. We do expectant management. When there's no high drops, we also do expectant management. But when there's a large CPAM and there's, or when there's a massive pleural effusion due to chylothorax, we might have to resort to a thoracoamniotic shunt. We can do serial thoracocentesis, or we can put a double pigtail shunt, which will go into the thoracic cavity and in the amniotic cavity. Remember, about half of the shunts may fall off. So we try to put the shunt at the back of the baby so that it doesn't have access to it. And the results for the chylothorax are reasonably gratifying. But always remember, a pleural effusion is a presumptive, or the diagnosis of chylothorax is by exclusion. And there may be other conditions which may be the cause of pleural effusion, which may come to light only after the baby is born. Lower urinary tract obstruction, on the other hand, is there are a lot of unanswered questions. We can identify a distended bladder with a dilated posturethra, and the question always comes is it a posturethral valve or urethral atresia? And our concern is the renal function preserved? Will these kidneys work in the long term? And will there be vesico-ureteric reflux? Almost all of them will have a vesico-ureteric reflux, and it takes a long time for it to regress after delivery. Now, when there is severe oligohydramnios, we can clearly conclude that this renal function is compromised, and the chance of lung hypoplasia, and they may not be good candidates for renal shunting. Now, the question in bladder shunting is survival. Is survival with long-term function.
Veronica, can you mute yourself?
So when
Sorry.
you put a shunt, so when you put a shunt, the shunt will allow more for amniotic fluid to come back, but and it will help the lungs to grow. But the renal function is something which may not be. More than 30% of them will go for renal transplant after about 4 to 5 years. So the when and how to treat becomes a big question. So if a standard shunting procedure, just as we do the thoracoamniotic shunt, we put a bladder shunt, only to say that the bladder shunt is more likely to dislodge than a thoracoamniotic shunt because of the location where it is put under the umbilicus. The umbilical cord constantly comes and rubs against the shunt, and the baby can also use hands to pull out the shunt. So another method which has been shown, which we have done a few cases, is to do a fetal cystoscopy. So here is a fetal cystoscope using a 1 millimeter scope, which goes into the posterior urethra. Then you identify the valve, and using a laser fiber with a low watt laser, you can just take multiple, you can make multiple holes in the posterior urethral to ablate the valve. But all these babies would require a full ablation after the baby is born. Right. Then we come to vascular occlusions. One of the conditions that come to our mind is chorioangioma. More recently, they have tried occluding vein of Galen aneurysm, but of course not with any measure of success. So we won't talk about it. In a chorioangioma, the concerns are majority of the chorioangiomas will do well. But when the chorioangioma size goes beyond 5 centimeters, we call it as a giant chorioangioma. And when the vascularity is very high, we can result in fetal anemia, cardiac failure. So the natural history varies. We've also seen chorioangiomas which reduce in vascularity over when we come to the third trimester. So for anemia correction, we do intrauterine transfusion, just as we do for any other anemia. We also have the option of doing an interstitial laser, where we can put go to the feeding vessel, do interstitial laser, or you can do a fetoscopic laser. You can see a large feeding vessel being ablated fetoscopy, or more easily done is using a histidal glue. So we do, we inject, we look at the feeding vessel and we put a 20 gauge needle and inject this glue, which instantly occludes the vessel, and then the chorioangioma becomes avascular. So it's a very gratifying procedure to do. Now, multifetal potential reduction, I don't want to talk too much about this because we know that there's a justification for doing reducing triplets to twins. We reduce because it reduces GDM by 70% and reduces preeclampsia by 60%, and less likely to be delivered before 32 or 28-week gestation, and less need for prenatal hospitalization. And of course, the procedure is straightforward. In a trichorionic pregnancy, you inject potassium chloride or lignocaine into the thorax, into the cardiac, into the heart, and to achieve asystole, which is easily done. The challenge is more with when you're dealing with the monochorionic triplets, when we want to reduce, where we have to resort to other methods like radiofrequency and bipolar cord occlusion. Then we briefly look at fetal therapy for complicated monochorionic twins. And there are several procedures which are done here: laser photocoagulation, radiofrequency ablation, bipolar cord occlusion, and interstitial laser. And depending on the condition, we will apply these procedures. Fetoscopy is done for twin transfusion stage 2 to 4 between 16 and 26 weeks, where we do selective laser photocoagulation. It results in about 76% at least one survivor and about 60% double survivors. The challenge here, of course, is the location of the placenta. For an anterior placenta, it's much more challenging as compared to a posterior placenta. But nevertheless, if you don't do a laser stage 2 to 4, or more than 95-97% of them, you will lose the pregnancy, lose both babies. For doing it is a chance for survival of either one or both. Now, selective fetal growth restriction is another condition where when one of the fetus is small and when the discordancy in the size is more than 35%, the ductus venosus showing more than 95th centile or reversal of A wave, there's a stuck twin, we resort to selective fetal growth, selective reduction. And selective reduction, we have two options. One is a radioablation, which is a simpler option. As you can see, we introduce the radiofrequency probe into the smaller fetus, and then we use 150 watts at 110 degrees centigrade. We do a 3-minute cycle, and once the cycle is completed, most often you can see cardiac asystole, which is being there. And then, if need be, we do a repeat cycle, and then we can take out the needle. On the other hand, if there's good amount of liquor, We can also do completely under ultrasound guidance bipolar cord occlusion. So here you can see a bipolar forceps being applied. We applied close to the fetal end of the umbilical cord because that's where the umbilical cord is narrowest. And then you can put a fetoscope to visualize how the cord coagulation has taken place.
Hello? Sir's gone offline. Sir's back.
I think we should wait for a couple of minutes.
No, he's back. He's back.
Yep.
Sir, you're unmuted. You're muted, sir.
Dr. Suresh, we are not able to.
Sir, you're muted.
No, I am trying to unmute.
Oh, okay. Thank
You are audible, sir. Now you are audible.
Now, did you see? Did
Yeah, we saw this, sir.
We saw this. Okay, next one. So next we come to trap sequence, which is again, I've gone through several rounds of discussion, lots of papers on what to do with the trap sequence, because you can see now trap sequence can be diagnosed from 9 weeks onwards. And there is also spontaneous cessation of flow in the acardiac twin in 60% before 16 to 18 weeks. So the question is, should we wait for it to stop on its own, or should we go and intervene? There are some proponents who say all trap sequences, you must treat them before 14 weeks. And at that time, of course, you'll get a 50% loss of the other twin, or because of so early intervention. But there are also, if it is spontaneously lost, they said there's also a chance of brain damage of the pump twin. So there's a trial called the TRAPPIST trial, which is underway, and we'll await the results of the trial. So in our series, what we do is we wait for 16 weeks. We don't intervene before 16 weeks. And if it's a spontaneously, if the vessel is spontaneously closed, then we don't do anything, just follow up. We have almost a 76% survival. But if you want to do a procedure, the question is to occlude the vessel which is going into the acardiac twin. And here, so what we do is a radiofrequency ablation, which is the standard procedure as you do for any other case. Put the radiofrequency probe inside the acardiac twin, and then usually one cycle should more than suffice. Or you can do a simpler procedure, which is an interstitial laser. So here, we just use an 18-gauge needle. We don't need anything else except an 18-gauge needle and a laser. So I'm threading the laser fiber through this 18-gauge needle. And once it comes, I look at the vessel at the hilum, and then I do a few bursts, and the vessel is occluded. The procedure takes only about 5 to 7 minutes. And we have, as I said, around 76% survival with this procedure. So complications of fetal therapy is center-specific, infrastructure, based on infrastructure, and also the expertise. It's also condition-specific. Now, certainly there's a learning curve for all procedures. And for diagnostic procedures, the complication rate is between 0.4 and 1%. Intrauterine transfusion is around 5%. Shunt procedures and fetoscopic procedures, the loss rate can be up to 40%. For shunt procedures, it is lesser. Fetoscopic procedures is much lesser, usually on average about 15 to 20%. And feto with balloon removal, 47 to 50%. The risk of neonatal death if emergency balloon removal cannot be done. And cardiac interventions, I've not shared all this because these are procedures which we don't do routinely in our center at this point. 10 to 30% mortality, and nearly 27 to 50% bradycardia and hemopericardia. Now, open fetal surgery is something we're not talked about because that's a whole new ball game altogether, especially for spina bifida. There are several centers in the world which do it. It has its own attendant issues in terms of case selection and the final outcomes. Overall, open fetal surgery for spina bifida or fetoscopic surgery for spina bifida have shown that lesser amount of shunting, postnatal shunting is required, and the motor milestones are a little better as compared to ones which are operated after birth. So I will leave you with some final thought process that fetal therapy is actually a multidisciplinary teamwork. You need antenatal diagnosis, clear diagnosis, and management, which says prenatal intervention, which will alter mode, place, and time of delivery, and also decide on the proper invasive procedure. And all of them will require a postnatal intervention at some point to take care. So fetal therapy is for right mother, right time, right procedure, and in right hands gives you the optimal outcome. And most importantly, I leave you with this message that we must know when not to do anything. There are cases where you say, I don't want to do it, and you can have good outcomes even because we don't do that. And we owe it to our mothers to do that. Thank you very much for your patient listening.
Thank you so much, sir, for this very brief and crisp overview of procedures. I don't see any questions in the chat box because Dr. Sita would have.
No, I don't think there's
We'll
any.
take it later on.
Yeah,
Yeah.
but some might not be there.
Some
but
might
no,
not be
Yeah.
there.
yeah, we'll have others to address it. Thank you so much, sir.
Thank you, sir. Thank you, sir, for your excellent lecture, sir. Thank you so much for giving and sparing us time for this webinar. Now I invite our second chairperson for the day, Dr. Pragya Mishra. And I request Dr. Pragya Mishra, ma'am, to invite our next speaker, Dr. Geeta Kolar, ma'am.
Very good evening to all of you. And at the outset, I would like to thank Dr. Bhaskar Pal, Dr. Sita Ramamurthy for having involved me for this fourth episode of Vision. And it is indeed after this wonderful lecture that we have heard from Dr. S. Suresh, we are moving on to another, I'm anticipating another great lecture from Dr. Geeta Kolar, who has completed her MD in obstetrics and gynecology from Government Maternity Hospital, Osmania University in 1987. She is a senior consultant in the field of obstetrics and fetal medicine at Fernandez Hospital, Hyderabad, with more than 30 years of experience. And her areas of interest are preconceptional counseling, high-risk obstetrics, use of fetal ultrasound for screening and diagnosis of fetal abnormalities, and invasive procedures and interventions. So I invite Dr. Geeta Kolar for her talk on prerequisites of fetal intervention.
Nice. Please stop sharing.
Thank you to the organizers of Vision for this opportunity to share my thoughts on fetal interventions in fetal therapy. 1 second. Right, are you able to see my slides? Are my slides visible?
No, not yet, madam. It's showing the, we can't see, the PPT is not opened on our screen.
It's your desktop which you're able to see.
Yeah.
Now, can you see it?
Yes, madam.
Yeah, we can.
Thank you. Thank you for this. And thank you, Dr. Suresh, for setting the whole field for me and making my job very easy. What Dr. Suresh shared was all the procedures which are being done, but we should know what are the prerequisites. If I'm going to do a fetal intervention, how should I go about it? What are the steps, and how will we really plan the procedure? So with that, I would be briefly talking to you about the history and introduction of fetal interventions. What are the goals? What are the indications? What are the types and prerequisites? And a few thoughts on the ethical considerations when you do a fetal intervention. So if you have noted the history of prenatal intervention, it started with the imaging. Ultrasound diagnosis, fetal imaging gave us a view into the womb. And in 1963, Lilly was the first one who, with a hysterotomy, did an intrauterine transfusion for fetal hemolytic anemia. He used the intraperitoneal route. And the third addition to our armamentarium was a fetoscopy. So these three techniques today form the bone structure of all the fetal interventions. If you have a good ultrasound machine, so if I have to just give you one sentence about what are the prerequisites, you have to have a good machine, you have to have the expertise to have access to the fetus through a fetoscope, and should know the expertise to do the procedures. So with good fetal imaging, with ultrasound, MRI, fetoscopy, doing invasive tests with the Human Genome Project and giving us the molecular diagnosis, today fetus has become a patient. It is possible that we diagnose, we intervene, we treat, we prevent. So all that has become possible thanks to these advances that we've had. So now we are able to diagnose the condition with ultrasound, give good prognostic factors of structural abnormalities, exclude genetic conditions, and with that, we are able to give options to the patients in terms of pregnancy termination for major lethal abnormalities like anencephaly, give them options of prenatal intervention like a surgical correction or an amelioration of known congenital defects in utero, or based on conditions like diurnal atresia, where nothing in utero is going to help, but we know a certain, if you've excluded a genetic problem, an active neonatal care can give a good outcome. So what is our duty then as a fetal therapy center? To support these decisions with appropriate level of care, regardless of what the patient chooses. So this, again, is important that we treat the fetus today as a patient. We treat the mother, we give her choices and let her choose. Right. The first conference of fetal medicine was held in 1982. And certain points that were raised then are still very, very useful for us to remember. They said this is the treatment of the unborn. So fetal treatment is nothing but management of the fetus with a correctable congenital defect. And this particular conference was attended by perinatal obstetrician surgeons, ultrasound people, pediatrician, bioethicists, and physiologists from centers who were active in fetal treatment. About 13 centers in 5 countries were represented. They all agreed to share information, establish a registry, and then provide guidelines for this promising and rapidly growing discipline. And what they said applies even today, that all cases, material, regardless of outcome, should be reported to a fetal treatment registry so that the benefits and liabilities of fetal therapy can then be established as soon as possible. So then how do we define fetal intervention with this background? All fetal interventions, whether they are medical or surgical, which are performed when the fetus is still inside a pregnant individual. That means before it is separated from the placenta at birth. So any intervention that you do on to a fetus which is still inside the mother's womb would be called a fetal intervention. And the routes would be percutaneous fetal interventions, fetoscopy, open fetal surgery, or ex utero intrapartum treatment. So we have seen some examples of percutaneous fetal interventions like multifetal reductions, IUBT, transplacental medications like goiter we saw, vesicoamniotic shunts we saw, selective feticide, and radiofrequency. Dr. Suresh has shown us examples of almost all these. Fetoscopy, again, he showed us example of treating a monochorionic twins with twin-to-twin transfusion and trap. Open fetal surgery is still done in very few cases, like meningomyelocele, where you open up the uterus, replace the fluid with saline, and suture it back. Ex utero intrapartum is you secure the airway while the fetus is still on placental circulation. This you do during a cesarean, you just deliver the fetus till its neck. And this is done when there are large tumors of the neck or of the tongue, where you know that the baby will have problem breathing. So you secure a very good airway while the fetus is still on the placental circulation. That means you're exiting the baby to an airway. And the method that you select mainly depends on the type of malformation, which is subject to correction. So the first line treatment generally involves this. If we have to start, we need to start with these minimally invasive techniques. Majority of these interventions would be performed between 18 to 30 weeks. After 30 weeks, it's a good enough time to deliver. Before 18 weeks, the veins and vessels are so narrow that you cannot intervene, except probably multifetal reduction, which we would do earlier. So the majority of the treatments are performed between the 18 to 30 weeks. So what are our goals or purpose? Why do we need to do these fetal interventions? First is to provide a cure or a prenatal correction. Like in the case of fetal anemia, you do an intrauterine blood transfusion. The fetal anemia is corrected, you monitor, you replace. Transplacental therapy, again, fetoscopy laser, you're actually providing a cure by coagulating the anastomotic vessels. Then even trap and selective fetal growth restriction, you're able to provide a good cure. Or you may be alleviating damage before birth or improve the sequelae. This we said, like in meningomyelocele, you would reduce the probability of shunt, the mobility, the bladder problems, you may be able to reduce. If there is CPAM or a huge hydrothorax, you may aspirate so that the lungs can expand. So you're alleviating the damage before birth and improving the sequelae, like you're allowing the lungs to expand and the baby to be able to breathe once it comes out. Or you may optimize transition to postnatal life. Like if there is stenosis, aortic stenosis, or arrhythmias, you are able to see that the baby is able to come to a postnatal life, the transition becomes smoother. Like I mentioned, also exit, where you're making the exit to airway easy. So the natural history of the disease can then potentially be infected. So if you know the type of, so the interventions, the prerequisites is knowing the defect. The first and foremost would be knowing the defect, trying to see what you can do by doing this procedure. Why are you trying to do the procedure? So unless we understand the natural history of the disease or the purpose of our intervention, there is no point in doing any intervention. So the prerequisites then would be doing a good advanced diagnostic testing. And this would form the first step. That means you confirm the diagnosis, the nature of the abnormality, the extent of abnormality, and rule out any associated defects. For this, you need good ultra-fast 3D, 4D ultrasound machines. You may need to resort to fetal MRI to substantiate your diagnosis. And to operate these machines, you need good fetal imaging specialists who have good experience in diagnosing birth. Like Dr. Suresh also said, you must know when to intervene, why you are intervening, and how to intervene. So prenatal surgery, in fact, is considered a preventive medicine. And the procedures which you're going to do should facilitate avoidance of disastrous consequences in extrauterine life. So you cannot reduce death to disability. That should be something we must remember. We're not trying to prevent death, but give a child with a lot of disability throughout their life. So you should facilitate avoidance of disastrous consequences in extrauterine life. So if you're going to do a procedure, do it with this motive. The only anatomic malformations that can be managed surgically would be where there is interference with fetal organ development. And once you remove these, you are able to allow their normal growth. So the biggest example is a congenital diaphragmatic hernia, where because of the herniated contents, the lung does not develop, and because of the pseudodextrocardia, the opposite lung also does not develop. So if you're able to push this tissue back into the abdomen, both the lungs, you can correct the dextrocardia and both the lungs can then develop. So if you know what to do and when to do and how to intervene, half your prerequisites are met. Then you always need an invasive test. That means a CVS or amnio to exclude any genetic possibilities. Because you know that congenital diaphragmatic hernia may also be associated with a lot of genetic syndromes. So the second prerequisite is, once you have made a diagnosis, is exclude any genetic associations, exclude any cardiac abnormalities, exclude any other associated defects. And the third one would be balancing the risk. This is an extremely different condition where you are actually, the fetus is a patient, but the transfer of your agents is through the mother. Since the mother is carrying the fetus, you cannot introduce risk to the mother. So you have to balance the risk versus benefits. Certainly, informed consent is taken. A comprehensive maternal assessment of a psychosocial, familial, social, moral, religious, ethical, and financial influences should be taken into consideration when you plan the patient's care. So the balancing act has to be done based on the maternal assessment of all these factors. Then the third prerequisite is, the core component is having a multidisciplinary group of caregivers. You should have these caregivers having the direction and oversight of the disease-specific care. So you need multidisciplinary inputs from perinatologists, anesthesiologists, neonatologists, nurses, cardiologists, an array of different specialties. And these interventions then should have a predefined team approach. And these, the team should have good expertise, experience, and know-how of the abnormalities. Then you need a good fetal therapy center, because you need to have a dedicated operational infrastructure which is capable of managing the maternal, fetal, and the neonatal complications which may arise either related to the therapy per se or as a part of the underlying fetal or maternal condition. So once you have accurately diagnosed, you've excluded genetic problems, where will you do the procedure? You will do it in a good fetal therapy center where both the mother, the fetus, and the neonate can be managed. The maternal care may need maternal fetal medicine, OBS medicine people, OBS anesthesia, and an intensive care unit. The risks of prenatal interventions in the fetus, if you combine all the risks, it is only prematurity which takes the maximum problems are of prematurity. So you need a center which can deal with these preterm babies, and this prematurity depends on the fetal status, the gestational age at which you have carried out the procedure, the degree of compromise that the baby has, the technical details, the maternal BMI, what are the other risk factors for her, and the operator and center's experience. So the center should also have good neonatology and pediatric surgery facilities so that once the baby comes out, it can be followed up with a good neonatal care. The additional support that you would need is social workers, data analysts, research regulatory and ethics, IRBs, and medical ethicists. Counseling and informed consent forms a very, very important aspect of fetal interventions. Once you have a diagnostic evaluation and you explain this to the parents, you give them a thorough understanding of the entire abnormality, what you're going to do, are there any alternatives to the procedures? By doing this procedure, what are the risks to the mother? What are the benefits to the baby? What are the potential fetal and neonatal outcomes? And what is an impact on future reproductive outcomes? Like you've seen, you do an open meningomyelocele, you're doing a hysterotomy, the mother, you're exposing her to anesthesia and a myriad of procedures. You're doing a low hysterotomy. What is the risk that this mother carries of having another child with a low hysterotomy? What are the chances of scar dehiscence in this pregnancy? So unless you explain all this in a very, very frank manner to the parents, it is very difficult for them to agree and give the consent for these procedures. The criteria which were adopted for fetal surgery as early as 82 even apply today. Again, he said accurate diagnosis and staging should be possible with exclusion of associated abnormalities. The natural history of disease should be documented, prognosis established. Currently, there should be no effective postnatal therapy. And this should have been tried in animal models where it has reversed deleterious effects of the conditions. And these interventions should be performed in a specialized multidisciplinary fetal treatment centers where there are strict protocols and approval of the local ethics committee with informed consent of the mother or parent. So these are the criteria that we must follow before we do an intervention. The ethical considerations should be given high priority. Again, when you are going to do it, you should know when to intervene, why, and how to intervene. What is the proposed intervention and what is you trying to prevent? Is this safe? Is it reliable? What are the risks to the mother? What is her mortality risk? What is the morbidity risk? And ultimately, leave it to this pregnant woman to make these decisions. So take an informed consent after complete information is given to her. Now, Dr. Suresh has already shown us about the IUPD, which will be the commonest procedure done in any fetal intervention center. And remember, like this is a case with second gravida, 27 weeks, the first baby was positive. She did receive anti-D, but she came with an ICT report of 1 in 32. That means there are presence of antibodies against positive cells, which may or may not produce fetal anemia. So how do we diagnose fetal anemia? Earlier, it was by going on repeating the titers, seeing if they are increased. Then we came to amnios where we do Lilly's curves or Spectra D 450. Then we started doing Cordo. But now we have from invasive, we have proceeded to non-invasive methods, that is middle cerebral artery peak systolic velocity. And depending on the moms, you can decide when to call her. And if it is crossed 1.5 moms, you know that the fetus is anemic, and then you can plan her intrauterine blood transfusion. So the way algorithm goes is if it's more than 1.5, but the gestation age is more than 35, you just see and you can induce labor. But if it is less than 1.5, do sequential MCA-PSV studies, and based on the zone, call her and plan her intrauterine blood transfusion. Remember that when the baby has hydrops, already the fetal hemoglobin is less than 5 grams per cent. You use O-negative, gamma-irradiated, saline-washed packed red blood cells to do the transfusion. The donor hematocrit should be above 75 to 85%. There's another case which came with gross polyhydramnios, a large mass occupying almost about 9 centimeters seen at the lower edge of the placenta. And there were 2 prominent feeder vessels. There was gross polyhydramnios, and by doing an MCPSV, we knew fetal anemia. So what do we treat? Do we treat the mass? Do we treat the anemia? Do we treat the polyhydramnios? So there are multiple options. You could do either a laser ablation of feeder vessels, do an amnio reduction. So the amnio reduction was done, about 750 ml was drained, 60 ml of blood was transfused, the hematocrit increased. So you know that there is not one procedure. Why I chose to say is there is no one procedure which you can say. If you treat the anemia, the polyhydramnios would land up in a preterm labor, the mass would still be remaining. So you have to do something simultaneously. So since there was significant anemia, we gave the transfusion. Since there was gross polyhydramnios, we did amnio drainage, and we did not attempt to do anything to the mass. Automatically, the mass, the vascularity reduced, but she set into preterm labor at about 31 weeks and had a good outcome. So the supportive therapies also need to be remembered, like amnioreduction, intrauterine blood transfusion, apart from the laser photocoagulation, or you could do a thrombosis of the feeder vessels with the use of microcoils. This is where you will attack the vascularity so that polyhydramnios can reduce and the mass can shrink. Right, this is another case, Primey, who had Graves' disease. She came to us at about 25 to 26 weeks with just twins, and both the babies had goiters. So first step is to find out the accurate diagnosis. The goiters may be euthyroid, hypothyroid, or hyperthyroid. Since the mother was Graves' disease, we did not know what are the possibilities. We did a photosynthesis and found out that the baby had primary hypothyroidism. Intraamniotic instillation of LT4 thyroxine was done, and you got a baby with a reduced goiter size. So to conclude, we need to accurately diagnose the condition before doing any intervention, differentiate it from all other abnormalities in the front and lateral aspect of the fetal neck. You have to exclude it from cystic hygromas, teratomas, assess fetal thyroid status by doing a photosynthesis. At any period of gestation, if the cord blood TSH is more than 12 milliunits, it is suggestive of hypothyroid status. The mothers may be hypo or hyperthyroid. The prenatal treatment includes intraamniotic injections of LT4, and the rationale for this is to optimize fetal growth and development and to reduce the size of the goiter, thereby relieving obstruction. So what is the principle here? When you inject thyroxine into the amniotic fluid, the fetus swallows the amniotic fluid in which thyroxine is instilled, and every 10 to 14 days, you may need to instill it again. This is another case. Unfortunately, the result was not that good. It was a huge big CPAM with pseudodextrocardia pushing the heart, and then a shunt was introduced, a thoracoamniotic shunt, but she came back with prematurity and delivered prematurity. Unfortunately, the outcomes may not be good in all these cases. There are recent trials of prenatal enzyme for lysosomal storage diseases, introduction of genes where there is genetic abnormality. So these are further trials of these interventions, and this is a PEARL trial, where in lysosomal storage disease, you're actually introducing the enzyme. And there are three basic advantages which they speak of. They say there is a prevention of the development of antibodies and or allergic reaction to the enzyme replacement therapy. You're able to deliver this replacement therapy to the developing brain where the blood-brain barrier is still permeable. This way, you're able to prevent damage to organs which can begin before birth. So more exciting things to come. Watch space for more action. So to conclude, prenatal interventions, accurate diagnosis and prognosis is the first step. If you do not have facilities, do refer to a center with sufficient expertise in diagnosis and all therapeutic options. Do counsel them regarding the risks and benefits of any intervention. Always take an informed consent. Offer intervention only if there's a good chance that the life of the fetus will be saved or irreversible damage where the disease or disability is prevented. They can be categorized into open surgical or minimal invasive endoscopic ultrasound guided technique. Multidisciplinary care is required. Therapy and interventions in an appropriately selected maternal fetal can be life-saving and can have the potential to improve survival and decrease neonatal mortality. Let's not forget the Hippocrates oath, which we all take. That's primum non nocere. That means I will apply treatment for the benefit of the sick according to my ability and judgment, but I will keep them from any harm and injustice. Thank you.
Thank you, respected ma'am. Thank you for that wonderful talk. Thank you for sparing time for us, ma'am. Sita, any
It
comments
was,
from you?
it was indeed a wonderful lecture by,
Yes, Pragya, go on.
yeah,
Yes,
yeah,
ma'am. Yes, ma'am.
it was a wonderful lecture by Dr. Geeta Kolar on prerequisites of fetal intervention. And she has said it all with so much clarity, leaving hardly any room for questions, I think. And the concluding remarks, in the concluding remarks, she has summed up everything so nicely, that one has to be very clear about the purpose of the intervention, when, how, and why. So at all these things and involvement of multidisciplinary care and so lots of things really which she has made it clear. I would just like to ask a very simple question, like how are the social workers involved in that? In one of the slides, she said about the social worker involvement.
See, the social workers assess their financial stability, how are they able to take care? So they need to know the background of the patient, be able to have some communication with them. So that is how the social worker helps, giving them psychosocial support also. Once the procedure is done, if they go back home, you need to bring them back for follow-up. So a psychosocial worker would help them to assist, they would assist them in this care before, during, and after.
Yeah, I think that's a very important, mediator between us and which we often miss, and patients get lost because they don't know, they feel intimidated to contact the doctors or they don't have the access. So these social workers can really be the bridging gap in, getting them back for and following them up. Thank you so much, Madam. I really wanted Madam to talk for one of our webinars, but finally we got her to. So thank you once again for being with us and sparing your valuable time. Thank you so much.
Listening to Dr. Suresh and the entire program.
Thank you.
The program is really well planned and designed. Thank you.
Thank you, Madam. Over to you, Sangeeta, Madam. You can.
Thank you, ma'am.
Yeah.
Yes, I invite Dr. Sangeeta Gupta, ma'am, to invite our next speaker for the evening, Dr. Anita Kaul, ma'am.
Yeah.
Can we have the
So
slides, Himanshu?
Dr. Anita Kaul is another national and international figure and hardly needs introduction. We all know that she's the clinical coordinator of Apollo Center for Fetal Medicine and a person to look upon. And I still remember those days when Dr. Anita had returned from London, joined Apollo, and had a lot of apprehensions whether obstetricians would be referring patients to me. And down the years, Anita, you yourself can palpate the difference which you have made in the perception of fetal medicine in the minds of all the obstetricians.
It's good. Yeah, that's true. Now they feel that we are an asset and add to their work, in helping them. So I think it's really good. And thank you, Sangeeta. You've been a support right from the beginning. So I really appreciate that. And all the other people who are here. Sita has sort of conned me into this talk.
Sorry.
So I'm very happy to, I'm trying to see where the screen share is so I get on with things. Where is it?
Below on your screen.
Right.
If you go to the bottom of the panel, there's a green.
Yeah, true. Thank you. So I'm going to talk about the do's and don'ts of basic things. I have to admit I'm using the RCOG guidelines a lot because they're just very good at sort of putting things together and in place. These are techniques that we do all the time, but we sometimes never think that there should be a SOP to it. So I'm hoping that I can present that so that it's kind of unified and standardized throughout. So we know that the goal of prenatal diagnosis.
Sorry to interrupt. We can't see your slides. We can see your desktop.
You are screen sharing, I thought. So what should I do?
Stop and share again.
Okay. I don't know why.
But as she prepares, I must thank her once again for, agreeing to do this talk and being there today with us. Thank you. Yes, we can see now.
So as you realize, and as I think all of us who are in the sort of business of babies, we always think that, we're not looking for perfection, and we should, as a society, accept flaws that we have. And as Geeta was saying, since NIPT came in, really, I do think that the procedures have come down because a lot of things can be determined earlier just by blood tests. And we have been able to prevent a lot of prenatal diagnostic procedures. But there are still some situations where you need to have it. For instance, if there's a structural abnormality seen on ultrasound, you need to test. If you know that there's been a previous history of some genetic disorder, for example, thalassemia, you suspect strongly that there could be underlying chromosomal abnormality or infections, increasingly so because now we're just much more aware of CMV and infections and the fact that we can treat them. So we're much more aware of that. Of anemia due to a variety of causes, including, again, parvovirus. And so when we have situations where we are suspecting problems, we do think that there is a role of prenatal diagnosis because it gives us a better diagnosis, a definite diagnosis, and therefore we can have more options in management. And as we are seeing, because, fortunately, the number of genetic meetings are also increasing alongside fetal meetings, because we are seeing that there is an increase in genetic disorders because of age or because of IVF conceptions leading to multifetal gestations, or because we've just understood things better. We have more knowledge now. We understand the genetic basis of disease much more. And now we believe that fetal diagnostic techniques are much, much safer than we did. So the two absolutely classic techniques are, of course, the CVS and amnions. And very rarely do we use blood sampling. But as I said, because since we realize that CMV is a treatable disease and people are on therapy, on antivirals during pregnancy, we do have to periodically check the fetal blood to look for viral load. The detection rate with any invasive is 100%. Say, for instance, if you do it for Downs, it's 100%. So even though NIPT is very, very good, it can never replace an invasive test. And, this is what one wants to be absolutely sure of, that you are looking at diagnosis versus screening whenever you do a prenatal test. What you shouldn't do, so let me start with amnios. What you shouldn't do is perform an amniocentesis at less than 16 weeks, because it's been shown that the miscarriage rate is about 2% higher. So it's safer to do a first trimester CVS than an early amnio. So it's always better to do a proper second trimester amniocentesis. The risk of miscarriage is much lower, and the risk of talipes and clubfoot is also much lower. So let's start with basics, which is the consent. You should obviously have an informed written consent, and these are the do's you should do. You should have a written consent where you consent for the fact that there is a risk of infection, which we consent for about 1 in 1,000. There's a risk of miscarriage, about 0.1%. Or there is a risk that there could be a failure in culture, which again is very low. We do allow a partner to come in with the patient because she needs to feel supported. And there should be some trained assistant with you who can talk to the woman and receive the sample when it's available. As I said, I'm going through the RCOG guidelines, and I'll tell you how we deviate from the guidelines when we come to our local condition. The woman normally is lying supine. It tends to be in the ultrasound room. Use a wedge if required. You don't need to give an anesthetic because amnio doesn't need that. And the most time is spent in trying to see which is a fetal-free area where there's a nice pocket of fluid. We tend to avoid transplacental. And in fact, I can't remember when I've done a transplacental because I would rather do a placental biopsy than do a transplacental amnio. But if that's the only way you can go in, then that's the only way you can go in. But remember that there can be maternal bleeding and it can contaminate your sample. This is what RCOG suggests, that there should be a sterile bag to cover your probe. There should be some screening agent. The syringe 2022 gauge, 20 mil to withdraw, and of course, drapes and swabs. This is what we use. We don't, we prefer using betadine and then also sterilium, so spirit after that. We use a normal 22 gauge spinal needle and aspirate, have a needle to aspirate for maternal cells and contaminated fluid, and then subsequently for the amnio. So I quickly made this video whereby you can see that. So we don't use this. We don't cover our probe because at King's, they didn't cover the probe. Essentially, Professor Nicolaides used to believe that in the area where you are going in, which is far and away enough from the probe, if that's clean, you don't necessarily need to go in. It's important that you push in the needle under ultrasound guidance completely all the time. You always, once you're in, we always discard the first little bit of fluid. So we tend to use an insulin syringe for this and just discard, because this could be maternal cells when you are going inside. And then you have the actual amniotic fluid that you're taking in. It depends on how much fluid you need. Normally about 20-25 mils is what you need for most tests. If we're sending off a whole exome, perhaps we may take a little bit more. But generally, you do reassure the woman that, you know, this fluid will be replaced really quickly, so don't worry. Always have one eye on the screen to make sure that no baby is coming, that you're absolutely fine and well away from you know, the fetal part. The removal, once you put your stillet inside, the removal also has to be under ultrasound guidance. You cannot blindly go in. It's important to obviously tell the mother that the baby is fine. So that is what you need to do. Next, cover the site. We use like a regular Band-Aid, very much. Make sure that the fluid that you've taken is, you know, properly labeled and identified, and this needs to be shown to the mother so that she knows that it's just hers which has gone through. So this is what we do, and it is pretty much with what the RCOG guidelines say, but they do suggest that you should use a cover. And again, the fact that you need to be continuously visualizing the full length of the needle during the procedure, you need to remove it. And the other point is that once you've done the procedure, should we give antibiotics or not? So we don't give antibiotics. It's not recommended as such by RCOG, but I can imagine that in India, we have such a heterogeneous group. If you feel that there is a possibility of infection, because remember, the main infection happens when you actually do the procedure. So if for the next 36 hours, the woman doesn't have any fever, she doesn't have any problems, normally the risk of chorioamnionitis is minimized, and you don't need, you know, so we tend to say that just for the next 36 hours, be careful. If you've got any fever or anything like that, report it to us. But if you haven't, you're fine. But I can imagine maybe this is a discussion that we can have afterwards, should you or should you not give antibiotics. As far as chorionic villus sampling is concerned, again, it should not be done before 11 weeks because of the risk of fetal transverse limb abnormalities or micronathia or microglossia. This is the sterile tray that RCOG suggests, where they have a sterile gel. And the bag, this is what we use. We don't have sterile gels. We tend to use our regular gel. We have a little a sort of connector, because we find it easier not to put the syringe directly onto the needle and go through a connector. And of course, you know, the media and the Petri dish, we find it easier to put the tissue in the Petri dish. It's easier to look to see how much we've got, and it's easier to pick it up to send it to the lab as well. So this is a old video of doing the CVS. Again, it's an outpatient procedure. It's essentially the same technique, except the needle here is much bigger. We use a Cook's 18 gauge needle. You have to ensure that you're in the placenta. So everything always is under vision. The only difference here is the mother is anesthetized. This part is anesthetized because it helps you in deciding the direction of needle. And secondly, it's more comfortable for the mother. You can see my colleague is connecting the connector to the stilette, aspirating, creating a vacuum. She would tell me that now there is a good vacuum, and you know, I'm sort of getting enough suction over here and checking that. Again, while you push it into the Petri dish, I can see very well that there's enough tissue up there, so it's a lot easier for us to do. Again, we don't use antibiotics after a CVS either, and again, we apply the same rules. If for the next 36 hours you're fine, then you should be fine. So what RCOG says is that if you are anticipating difficulties, request help from a more experienced operator. If you've had 2 attempts and you've failed, then you really should get help from a more experienced operator. That it's okay to do that 15 to 20 mil. It is important that you demonstrate a FHR to the patient. You need to give anti-D prophylaxis in case of Rh negative women. You need to tell the female that she may experience mild abdominal discomfort for the next 24, 48 hours, and she can take paracetamol. And if there's anything more severe than that, then she must, you know, immediately speak to the doctor. What are the risks that doing any of these procedures can cause mother to child transmission of infection? And when we are talking of infection, we are mainly talking about HIV and hepatitis B and C. So at least one should have a kind of knowledge on what is the status of the woman before you do the procedure. If she is indeed HIV, the antiretroviral treatment should be optimized to aim for an undetectable viral load prior to amnio or CVS. Hepatitis B, the risk of transmission is very low, but at least be sure that it is very low. And as far as hepatitis C is concerned, there's no evidence that that goes across to the parents. So if you look at amnio and CVSs, on the whole, they are quite similar. It's not, obviously there are advantages of amnios like confined placental mosaicism that is not there in amniocentesis, but in a CVS, there is a chance. And indeed, when you consent for CVS, you do tell them that there is a chance of CPCs, which is less than 1 in 1,000. There is the chances of maternal contamination, of culture failure, or infection, or whatever. It's all very rare, but it is sort of reasonably similar. Different people have said they've given different figures for procedure-related risk of miscarriage. And it is true that in the hands of experienced operators, they do much better than the ones who are starting the learning curve. If you're doing a twin amnio or a twin CVS, and obviously in twins, amnio is preferable to a CVS, you need to give an additional 1% risk for each fetus. these were the risks we were quoting until this meta-analysis of Okoliker et al. Came out, where they analyzed that there are women who would anyway miscarry, and all the procedure-related risks that had been quoted earlier did not account for the fact that sometimes when there was a problem, they would have anyway miscarried, whether you did an amnio or a CVS or not. So when they removed the bias of all this, they realized that actually the pooled procedure-related risk of miscarriage for amniocentesis was barely 0.1%, and for CVS was 0.2%. So it wasn't as high as 1% and 2% as sometimes is quoted. And therefore, that is what we quote as well. Once you've learned how to do invasive procedures, how do you make sure that you maintain this good practice? So RCOG does suggest that you should do a minimum of 20 amnios or CVSs per year. Constantly keep auditing yourself. Do you have to do multiple insertions? Were there failures? Were there bloody taps? What was the chance in the next 2 weeks that there were losses, that the woman had preterm births, she went into labor or prompt? And if by chance the annual loss rate is more than 3%, it is better that you get retrained again, because you are not maintaining standards. And there is, I mean, I know in India it's actually quite difficult to get training. Even we ourselves, we get people saying, well, can we come to you for training? But we say our responsibility is to our fellows first. And, you know, in a private setup, it's actually quite difficult to train. But there is a lot of now simulation training, which is coming on. A lot of situations that when the person is doing it, they can be supervised. And of course, in the government hospitals, they are providing training. So the implications for current practice is that these invasive procedures are actually much safer than has been currently stated. You get, you know, the learning curve is such that you get better as you go along, and your procedure-related risks become much lower. But at the moment, this is what we quote. And because now there's so much information to be gained from genetic tests, the fact that, you know, Veronica, I'm sure will tell us more about it, but because genetic diagnosis has sort of taken such great steps forward, it would be unfair for genetic tests not to happen because the obstetricians are scared about the risk of miscarriage. The risks of miscarriage are much, much lower than you imagine. And really, I always believe that, you know, in couples where there is some doubt, it is better to do a genetic test and do a prenatal intervention, and you know, make this couple access the amount of information that's there. So Sita, I'm taking this opportunity. So thank you everyone for a patient hearing, but I'm taking this opportunity to invite all of you to our Dehradun conference, which is going to be multiple pregnancies and echo. So I hope to see you there. And thank you all very much.
Thank you, Dr. Anita, for this very clear and, you know, a good talk. We probably all know all this, but to put it together, sum it up in such a simple way was really which has put forth it very clearly for all of us. I just wanted to contribute a few points which came to my mind when you were saying all this. It is also very important that we we are very prudent in completing all the regulatory formalities, like filling up those F forms, G forms, and D forms, and filling up the test requisition forms very, very meticulously. Because if you don't attach, if you're probably doing a chorionic villus sampling or an amniocentesis for a genetic disease, and you don't attach the mutations of the index case or the parents, then probably the lab may not exactly know what you want. And the second important thing is the correct labeling of the samples, instant and correct labeling of the samples. And as far as the procedures in twins are required, one should be very clear that the procedures, even the diagnostic procedures in the twins, should only be done by those experts who are also capable of handling in future if fetal reduction is required. So these were the few points I wanted to share from my experience. And
No,
I
that-
just want to share one more case which I'd encountered during my practice. And I want to bring it forth to everybody's notice because nowadays we have a lot of patients with previous cesarean sections coming. So I had a patient who was posted for chorionic villus sampling. She was a case of previous cesarean section and she was undergoing a sampling for thalassemia. Nevertheless, when I was scanning her, there was constantly in my field where I had to approach the placenta, there was a bowel loop, which we just could not get rid of. And I abandoned the procedure and we converted her to an amniocentesis. And when we did the cesarean section, there was a bowel loop stuck on the previous cesarean scar. So it's very important to, not only follow the needle in utero, but while you're introducing the needle from the skin and into the uterus, the intermediate zone of the abdomen should also be carefully looked for.
Right. Thank you for these very important points. I keep forgetting PCP and DT for some reason, though they harass us so much.
So,
Thank you, dear ma'am.
yeah, it was a wonderful
Thank you for the
lecture.
Excellent talk.
Yes, Pragya ma'am. Go ahead.
No, I was just saying now that the age of MTP has gone up to 24 weeks now. So I think perhaps, amniocentesis well. So it is normally done between 16 to 18 weeks. But at least because of this and a lot of times in our scenario, patients, they turn up late. It's only after the level 2 scan where they present to us. So I think it has given us some leeway, to do amnio at even a slightly later gestational age, which is good. It's easier.
Right.
Because like as you were saying, that you've never had to go through the placenta, and like most of us, we try to avoid going through the placenta. But in one patient, there was no way that I could have avoided the placenta. Then I called her back after a couple of weeks. Then after 2 weeks, then it was easy. The placenta had actually gone up a bit, and then it was easy for me to take the sample. So that's another thing that sometimes, we can postpone it by 2 weeks. Or in one case, what happened that the LICA was a bit less when the patient was called at 16 weeks. Then some gave her some empirical treatment like LRG and things like that, which we normally do. Again, called her back after 2 weeks. So it was quite comfortable for me to do the amniocentesis after 2 weeks. So just practically, from my experience, I was.
Important point.
We have a question in the chat box, Anita ma'am.
I think that is for
someone is asking where.
Dr. Geeta, I think.
Yeah, that was for Dr. Geeta Kolar, I think.
She's there. Madam is there. So
Yes, Dr. Geeta ma'am. In how many days can we expect the fetal goiter to reduce after we have done some intervention?
and how do we follow them up?
That's for me?
Yes,
Yeah.
ma'am.
Yeah, see, the thing is, we start when we see the goiter, every 10 to 14 days we give it. And the goiter may or may not reduce, but what it definitely does is replacing their thyroxine levels, and it helps in growth and development. What we have seen is certain reduction in size. So every 10 to 14 days, we keep insulin, considering the baby's need requires about 10 micrograms per kg body weight. So there is an endovascular circulation. It keeps drinking, keeps passing urine, again swallowing. Yes, till birth, we have to follow it. So it's not how many days. I'm not looking at how many days it will shrink. By the time it is born, I wanted to have a significant reduction so that there is no pressure, there is no breathing difficulty for the baby. So the purpose is, yes, promoting growth and development in the fetus, reducing the size of the goiter so that the pressure effects and the breathing difficulties don't increase. So all these purposes are meant by putting in intramniotic thyroxine.
Is this L-thyroxine easily available in the market?
Not at all. It is a tough job to get it. It's a
Yes.
I think it's very expensive also.
Yes.
Yeah, very expensive also.
Yes. And we had this
Thank you.
lady and we had to put it in both the sacks, yes. But it was worth
So
it.
how does one get it? I mean, because I still remember, before also people have asked this question about L-thyroxine. It's not so easily available, for quite expensive. So, like, what do you do? Which company?
There's only one company, ma'am, which makes it, and you have to just see there's something called a gray market. No, for all these medicines, you have to really try. And patients often get it. They manage to get it for us. We've got it for whoever. We have about 8 cases we have instead, and excellent results.
I think Dubai and all.
Yeah.
Yeah.
So well, even some critical care people have told us it's available in some hospitals who deal with critical care, because it's only there that you use them. Otherwise, the tablets are so inexpensive that you rarely need this parenteral administration.
Right. Ma'am, do you always do intraamniotic installation for this?
Yes, you need to do only. You can't give such a high dose into the vessel. You need to do only intraamniotic.
Okay. Thank you, ma'am. Thank you for answering that query from the delegates. And now, Himanshu, can we have the, I really thank, first of all, I really thank all our respected speakers, Professor Suresh, Dr. Geeta Kolar ma'am and Dr. Anita Kaul ma'am for delivering those excellent talks and sparing time for our 4th episode of FetoVision webinars. I thank our respected chairpersons, Dr. Sangeeta Gupta, Dr. Pragya Mishra. Thank you for sparing us time, ma'am. And we wrap up this first session of the talks for this webinar, and I request everybody to stay along with us, and we have a small industry video which will be running now. Himanshu, please.
From the sandy shores, where a couple stands hand in hand, witnessing the birth of a new day, to the boat sailing towards the horizon, seeking its abundant catch, the rising sun signifies a fresh start, a beacon of light guiding us towards a healthier future. A mesmerizing sunrise, symbolizing hope, transformation, and possibilities heralding a new beginning. Just as the sun's rays fill the sky, illuminating the world around us, we at M-Fine Diagnostics are here to illuminate the path to a healthier tomorrow with the promise of transformation. In this symbolic moment, we invite you as M-Fine Diagnostics, formerly known as LifeCell Diagnostics, embarking on a journey to revolutionize India's healthcare system. With the recent acquisition by LifeCell Diagnostics, M-Fine Diagnostics combines the strengths of 2 leaders, forging a path towards a healthier India. Our commitment to excellence, nurtured by years of experience, will redefine the way healthcare is delivered.
At NRL, we cater to a test menu of 3,000 plus tests. These are all specialized tests, and they cover various high-end specialist tests like genomics, karyotyping, FASH, newborn screening, prenatal screening, immunohistochemistry, allergy, and flow cytometry.
Come, let's explore a realm of innovation and compassion. Here, the convergence of science and care sets the stage for a new era in healthcare. Inside our state-of-the-art facilities, skilled medical professionals work tirelessly, employing the latest advancements and breakthroughs. We believe in leaving no stone unturned in our pursuit of accurate diagnostics and comprehensive care. With M-Fine Diagnostics, you can trust that your and your patient's well-being is in the hands of dedicated professionals, guided by a shared vision of transforming lives. At M-Fine Diagnostics Lab, we combine expertise, advanced techniques, and timely reporting to provide you with the most reliable histopathology services. Trust us for accurate diagnoses and comprehensive solutions. Our integrated departments and highly trained professionals equipped with advanced technology deliver high-tech tests with speed and accuracy. Automated sample management guarantees faster results, while our focus on quality is unwavering. At M-Fine Diagnostics, we prioritize seamless experiences for patients and doctors. Our dedicated customer care ensures hassle-free services, Patient convenience is key, and we offer real-time logistic tracking, allowing patients to stay informed about their specimens. With strong logistic support and real-time sample tracking, we ensure smooth operations. Our mobile application provides a flawless user experience, enabling easy test searches, bookings, and result downloads. Our enhanced customer experience includes auto-routing bookings to the nearest available phlebotomist and a user-friendly portal/mobile app. Our skilled phlebotomists collect samples efficiently, maintaining specimen integrity during transport to the lab. Adhering to NABL and CAP guidelines, we uphold the highest quality standards in the industry.
Together, we can set new benchmarks of performance and excellence across the country. We are excited to collaborate with you in catalyzing game-changing diagnostic innovation for those who need it most. Thank you for your support.
Thank you. We again take this opportunity to thank our industry partners, LifeCell and M5 Diagnostics. Now we move ahead to the very exciting panel which we have for this evening on genetic testing. And I invite, we have two moderators will be moderating this panel. Can we have the slides for Dr. Sita Ramamurthy? I am a consultant of fetal medicine and obstetrics at Apollo Multispeciality Hospital, Kolkata, and presently she is the chairperson for the Fetal Medicine and Genetics Committee of FOGSI and also the president of the Society of Fetal Medicine Bengal chapter. I welcome you, ma'am, for this panel. Next, please, Dr. Veronica's slides.
Himanshu, next slide, please.
Dr. Veronica Arora is a consultant in clinical genetics at Gangaram Hospital, and she is a clinical genetics gold medalist, and she has multiple laurels to her name. I welcome Dr. Veronica Arora to moderate the panel along with Dr. Sita Ramamurthy Pal. Welcome, Dr. Veronica.
Thank you. Thank you.
I think you can call the panelists as well, yeah. Introduce. So thank you, Prasanna, for that introduction. And now we've heard the procedures, how they need to be done. And we have the lab providing us with all the array of tests and, from top to bottom, whatever they can offer. And here we're going to talk about with my very learned moderator, Veronica, we are going to talk about which test to do when and what can we get, what is the best yield we can get from them. So invite our expert panelists. First one is Dr. Gina Bordoli-Deca, who's done her, she's a radiologist and has done her PG diploma in MSK ultrasound from Spain. She's trained in fetal medicine and is currently the director of the Dispur Polyclinic and Hospitals, Guwahati, Assam. And she's also the secretary of the SFM Northeast chapter. Welcome, Dr. Gina, to our panel. And next we have is Dr. Jyotsna Gupta. She's a senior consultant of OBGYN and maternal fetal medicine specialist at the director and chief consultant at the Promise Fetal Medicine Jalandhar. With over 10 years experience in fetal medicine, has also done her advanced fellowship in advanced fetal maternal medicine. Welcome, Dr. Jyotsna. Next, we have Dr. Manisha Beck, who's the professor and head at the fetal medicine unit at the Christian Medical College, Vellore. And she, congratulations to her because they've just started the fellowship there for fetal medicine. And welcome once again, Dr. Manisha, to our panel. Next, we have Dr. Shashwati Mukhopadhyay, who's again the clinical geneticist at Apollo Hospitals, Kolkata, and with her giving inputs on the genetics benefits. So thank you, Dr. Shashwati, for being here. And then we have Dr. Vandana Chadda. Thank you, Vandana, for joining. May I have the next slide, please? Yes. She's honors the ICBSE topper, and she has a lot of laurels to her credit as well. And right now she's presently designated the director of the Satwa Fetal Care. And we all know about, she another person who doesn't need introduction, a lot of achievements in her career and papers, publications. Thank you, Vandana. And last but not the least, we have the young fetal medicine specialist, Dr. Vinayak Das, who's actually the consultant at New Ramakrishna Seva Sadan, Siliguri, West Bengal. And he's done his fellowship in advanced obstetric ultrasound. So thank you and welcome once again. I'll just share my screen. Yeah. So can you all see our slides? Yeah. Okay. So we're going to talk about which genetic test where. And so as we've heard that, the prenatal genetic testing has evolved rapidly, and it started off initially in the pediatric population, and then it gradually shifted to the prenatal period. And now we can really offer a lot of information, with the array of information we have every day. We can allow the genetic diagnosis to go to single base pair levels, but obviously we need to understand this. And so the clinician knowledge and awareness of the options available to the women and the obstetrician also needs to be familiar about what's being done and the importance of it. So as we see, we need a team approach, and that's what we have here. We have an obstetrician, a fetal medicine specialist, a geneticist, a neonatologist. Yes, we do need them when we require their help in terms of an anomaly that needs to be corrected. And that's what we have here, our experts. We've already introduced you to them. So quickly going on, Dr. Manisha, will you just tell us what in our current, with the evolving array of tests that we have and a lot of genetics coming into, coming into our practice, day-to-day practice, what would currently be the indications of genetic testing in our obstetrics practice in this era?
Thank you for that question. So basically, there are different types of genetic tests and indications for the genetic testing. In our specialty, especially as fetal medicine, the first and foremost would be prenatal testing. Now, prenatal testing is when you test the fetus for various indications. For example, if there's a high risk for aneuploidy, or if there's an ultrasound which shows some abnormalities. Or it could be carrier testing. Carrier testing is where the baby has a problem and you would want to test whether the parents are carriers of the same problem. So in that context, you do the parental testing for the same. Then there is something called predictive or pre-symptomatic tests. Now, these tests are basically done if you have a family history of a genetic disorder and you know the faulty gene, but you are still not symptomatic, you are asymptomatic. So this predicts your future risk of having that disease because of that faulty gene. So those are known as predictive or pre-symptomatic tests. Now, there's something also which is on the horizon that is called pharmacogenomic testing. In this kind of tests, what we do is we use the genetic test to see how a person responds to certain drugs because of his or her genetic makeup. So this is pharmacogenomics, and it's coming up in a big way. The various clinical scenario in which we would be using these tests is, for example, let's say a case of, let's say a family history. For example, recently we had a mother with myotonic dystrophy. Now we want to know whether her fetus is affected or not. So you would be doing a genetic test to see that. Or as we said, if there is a family history of hemoglobinopathy like thalassemia, the first child is affected, or the first child has got cerebral palsy, global developmental delay, or if there is a recurrent pregnancy loss where you would want to rule out any parental balance translocations, or premature ovarian failure in the mother where you would like to rule out Turner mosaic. So these are some of the common indications of clinical scenarios where you would actually employ a genetic test.
Thank you, Manisha, for that, for the clear indications that you've said. But usually in our antenatal practice, we usually come up, with this aneuploidy screening or something found on ultrasound. But it is important to remember that, we need to take a history, a proper history as to what, and if they've had a stillbirth, which is so-called unexplained, it might not be actually unexplained. And we need to go further into that without just assuming that it was unexplained or it was something else. So, Dr. Shashwati, if you sort of say what the genetic tests are available, how would you classify? I mean, how do we start off in the first place before we do any genetic testing, or and what would be the various type of tests? Just a brief overview so that we can go on to the cases quickly. Yeah.
Yes, first of all, we should take a pedigree charting. That means we will take a 3-generation family history. Thereafter, from the family history, then we can see if there are any affected individuals or not. And then we moving on to the chromosomal tests. We can go for the FISH or the QFPCR, the karyotyping or the CMA. In case of FISH, we should have some idea about which chromosome which chromosomal anomaly we are dealing with, which microdeletion, and
Yeah.
thereafter we can go for the actual probes. In the QFPCR, we really go for the aneuploidies. Karyotyping is again, we can go for we can see if there's any translocations or inversions, any structural anomaly
We'll
or
come to
numerical
the
anomaly.
details of these tests, but I just
Yes.
wanted you to classify as, what would be the chromosomal test and what would be the single gene disorders that you
Yes.
check.
Monogenic disorders, we can see either we can go for the Sanger sequencing if the specific gene is known. In case of deletion duplication, we can go for the MLPA. And if we are not very sure of which gene we are dealing with, then we can go for the panels like exome sequencing.
So can you just explain to us how we've sort of, why are we doing this and what are we looking at actually by these tests? A brief overview of the DNA structure. We all know that, every cell has its nucleus and the chromosomes are densely packed. And as you unravel them, we tend to see that the genes are there and it's closely packed. And then we have these 4 base pairs that we're looking at. So we can go from anywhere from, as we said, chromosomal testing to the single gene disorders. Right.
Yes.
So we gone to the first case. Thank you for that, Dr. Shashwati. So this is a 26-year-old primary gravida who was an IVF conception. She had an NT scan. She came at 12 weeks, but her combined risk was 1 in 50. And the PAPA values were around 1.1 mom. So Dr. Jyotsna, she comes to you with this report. The scan was reported as normal, and obviously she doesn't go back. She comes to the obstetrician with her combined FTS report. What would your advice be for her at this stage, and why?
Thank you, Dr. Sita, for this opportunity. Now, first and foremost, the moment I see this, I have to tackle 3 questions. First, I have to tackle the aneuploidy risk. Second, I have to tackle a low PAPA. And third, and the most important, counsel the patient accordingly for all the risks which come in her way. So we all know a PAPA less than 0.4 MOM is associated with the risk of preeclampsia, preterm delivery, a BOH. Then aneuploidy screening at a risk of 1:50 needs an invasive testing. And then counseling the patient. And then again looking for a proper scan also here, that the NT scan was done according to the FMF guidelines. The anatomy or the early morphology was seen nicely. The Dopplers were done so that we can evaluate the risk for preeclampsia also. So these are the 3 things which need to be done.
Absolutely. So you are clear that she needs an invasive, right?
Yeah.
Does anybody differ in that? Any of the panelists? Can't see them because my slide share is on. But does anybody differ in what?
Can I speak, Dr.?
Yeah, please, yes.
So I think this lady is, though she's like 26 and it's an IVF conception, she's a young patient, but it's still an IVF. So one might just look at the ultrasound parameters carefully, and if we don't find anything on the ultrasound experience enough, probably I would like to give her both the options and then not really say that only invasive is the option. I would perhaps also give her the option of NIPT and invasive both. And then she can choose if she wants invasive, or if she doesn't want to go for the risk of miscarriage, then she can opt for the NIPT also.
Right, that's interesting. So we did say that, because a lot of times IVF, as she rightly said, IVF conception, the minute we talk of an invasive, they say, oh, the risk of miscarriage is there. However, we we say it's 0.1%. The minute you say the risk of miscarriage, that sort of falls into their head. But yes, with a 1 in 50, I think most of us would recommend invasive. But yes, it's up to them to decide, isn't it? So that's what was told to her, and clearly, IVF conception, she decided to go for an NIPT, and this was the report. So we have a fetal fraction was 3.2%, trisomy 21. It said as high risk. The others were all fine. So was Dr. Vinayak, was this the right choice? We discussed that. What next? I mean, this report we have with us, she waited. And if we go back, she was actually 17 weeks, We did tell her to go ahead and do the test at that point, but she went back and then she came. So by the time we got the report, she was 17 weeks. So do you say no testing, or would you directly go for intensive, and what not to do would be your advice?
So firstly, thank you, ma'am, for the opportunity. So in this patient, I would definitely go for invasive testing to confirm if there's a trisomy 21 positive or not. And what not to do, I will avoid an karyotype. Since the PAPI is very low, 0.1 mom, so there is a chance that there could be some microscopic deletions or additions. So I'll go for microarray at least in this test. And I'll go for amniocentesis with low resolution microarray in this case, ma'am.
What would be the first advice you think that not to do? Because, she'll go out in the community and they will say, terminate, isn't it? So the first thing that we
Yes,
must
yes, yes.
awareness, please do not terminate on the basis of this test. Yes, we need to confirm whatever it is. So, so you're going to say an amnio. So what if she had come at 13, she had agreed to come and, she was around 12 or 13 weeks and she agreed to do a CVS. Would you be concerned if, if there is, what I wanted to actually ask is, were there any false positive NIPTs? Dr. Gina, can you take that up?
So we need to tell the patient that, if you have a positive NIPT, it is still a screening test.
Yeah.
No doubt, it has a very high detection rate of almost 99.7%, but then there's always a chance of a false positive rate of almost 0.04. So the patient needs to understand that it is a screening test. And so we might get false positives in basically vanishing twins, or in case of placental mosaicism, or several other conditions like, if we've got to ask if that, there might be maternal mosaicism, and then there might be some problem with the lab, or even, there are other conditions like recent blood transfusions or malignancies, or, we've got to take a proper history. But yes, even vanishing twins and placental mosaicism, they might give a false positive, and we've got to explain to the patient that, this is a screening test and you've got to go for an invasive before
Absolutely.
confirming. Yeah.
Yeah. Nowadays, a lot of the countries in the West, they're moving on to a early screening, first screening with NIPT and NIPS rather. And then if it comes back as positive at early, would you prefer doing a CVS or you wait for an amnio? And where is the concern of placental mosaicism?
Yeah, so it's better to do an amnio, I think, when you have a positive NIPT, because as I said, a placental mosaicism can give rise to a false positive NIPT. So to avoid that, it's better to go for an amnio after 16 weeks.
But if the NIPS comes back as positive for trisomy 21, do you think the placental mosaicism is of concern? Veronica, you can chip in as well whenever you want. Dr. Vandana, do you want to sort of say about
the risk of placental mosaicism is less for the trisomy 20. In fact, I think over the years, the false positive, I just remember often one false positive NIPT trisomy 21, whereas we get false positives for trisomy 18 and 13 and these all the time. So I just remember one case, and all of the others, and we've had lots and lots of them where the NIPT positive trisomy 21 is almost always translated into amnio. But having said that, I still feel that I personally prefer to do an amniocentesis because I feel that is a better representation of the fetus. And by the time we do an NIPT, it's usually around 12 weeks. And by the time the results come, the baby is usually around 14 weeks. So I think it just kind of fits the whole.
Yeah. So as Vinayak was saying that he wouldn't do a karyotype, he would do if it comes back. So if you do an amniocentesis, would you?
I think one has to do a fish to rule out the mosaic part, and then the microarray. So my combination usually for a NIPT positive is a fish combined with a microarray.
So karyotype is out, you're saying, or what would be the indications for karyotype
there are hardly any indications now to do a karyotype per se, but yeah, if you want to look for balanced translocation in a parent, that's when you do a karyotype. But most of the other situations, we either do fish or we do QFPCR or we do microarray or a genome, depending on the.
Yeah. So this is one recommendation I found in one of the studies, that they said if there was high result, high chance for 18-13, you have a detailed scan again, and if they find a normal scan, then you could offer the amnio. But if it was gross structural anomalies, which would mean that it's 18 or 13, you would see them. They have said that you could give the options of CBS or amniocentesis as well. So this is, I put it up because I found it a bit debatable, isn't it? So I just wanted.
So the other thing is, if you do have gross structural anomalies, a lot of time, at least in our scenarios, you terminate. So
Yeah.
again, in a practical setup, you have a normal looking fetus, you have an NIPT positive, the baby's already 14, and you really want clean results, then we usually go for the amnio at 16 or something. And you do combination of FISH and microarray. So this is how it plays out most of the time.
So this lady had a FISH and a karyotype as well. This was quite a long time back, of course. And it was trisomy 21. And obviously they terminated the pregnancy. So Dr. Shashwati, would you, now obviously it was an IVF pregnancy, she was really heartbroken. And what are the recurrence risks? And this was self-eggs, I must say that. This was her own eggs, not a donor egg. So what are the implications for her? She was a young patient and she never thought that it could happen to her. So,
So here there is a translocation, there is a trisomy 21. So in this trisomy 21, if it's just the recurrence for risk for trisomy 21 is actually 1%. But if we have a balanced translocation, if we have a translocation downs, in that case, we will have to go for karyotyping the parents. Now, if the parents turn out to be, one of the parents is having a translocation, if it's the father who is carrying the balanced translocation, then the recurrence risk is less than 5%. But if the mother is carrying the translocation, balanced translocation, the recurrence risk is about 10 to 15%. But sometimes now the translocation is also de novo translocation also is present. So if we have normal parents with a translocation downs in the baby, then we will have to think of gonadal mosaicism in the mother. In that case, the translocation, then that chance of translocation, recurrence risk for that will be about 50%.
Yeah. So as Dr. Vandanan, she also said, karyotype is actually going out of the scenario now. We only do it for looking for balanced translocations where the unbalanced would affect the fetus. And it's usually the karyotyping of the parents when you want to determine the risk. So this is some interesting case which Dr. Shashwati just had in her clinic, that this was a child with 21 translocation, and the elder sibling was normal and the karyotype of the parents was done. And do you just want to tell us about this quickly?
Yes, this couple had come with the, as you can see, the translocation down in the younger child, and with a 21 translocation. So I asked her for other children in the family, and she said, yes, I have an absolutely normal 11-year-old, 7-year-old girl. So then I asked her whether this is confidentially, I asked her whether she belongs to the same parents. But she told me, yes, she is my child. So in that case, we were thinking that karyotyping of the parents and the elder sibling should be done to rule out whether it's a de novo translocation, or we are looking at germline gonadal mosaicism. But however, she has not yet come back, possibly because of the financial constraints.
Yeah. So that's what you have to say, whether it's a Robertsonian translocation where, if there is a 21 translocation, they will always have a Downs offspring and they'll have to consider other options in the next way. So just quickly, doctor, you can tell us, how does FISH differ from QF-PCR, and what would be the right test in terms of, looking, if you had such a scenario, would you recommend one, or which one would you recommend over the other, and why?
For translocation, balanced translocations,
No,
if we are looking.
generally when we are doing a test, as we are, suppose the similar case, you're looking high risk for trisomy 21 or whatever, would you recommend one over the other, and why? Which one would, just for our information?
Well,
Both are
QFPCR can
rapid.
be,
Yeah.
yeah, both are rapid tests because the results are coming between 24 to 48 hours. No, sorry, 48 to 72 hours it will take. Because in fish, it is an interface test, but in QFPCR, the DNA is extracted and it is, we will look at the markers, whether it is I mean, three peaks are present or whether it is one large peak and one small peak, or we are looking at very large single peak. In that case, we can confirm the QFPCR by QFPCR. We can confirm the trisomy. We can confirm the trisomy. But in
So,
case of cat,
yeah. Fine. So, Dr. Manisha, in your practice, what do you normally do? If you're sending a sample, obviously it's better when you're putting a needle, you have to be absolutely sure what you're testing for. So, in this typical case, when we were doing the amnio, do you recommend, do you do a fish or do you do a QFPCR? What is your practice in your practice?
So we would generally do a QFPCR, rapid aneuploidy testing. But having said that our cytogeneticists do process on to do the CMA also in case the QFPCR comes back as negative. So that is as a backup. Yeah.
So how do you add one point that when you want to detect mosaicism, that time you prefer fish, and a lot of times we have like we've already taken out extracted DNA of the fetus. For example, when I do a early CVS for thalassemia, I'm already doing a DNA based test, so I would prefer to do a QFPCR there because my sample may not be adequate to do extra fish. So we've already extracted DNA, and my lab will quickly do a QFPCR for me to give me an assurance about the trisomy as well as the thalassemia mutation.
Right.
So that's
My
the
other question, that's actually useful to know. My other question is, if the report comes back positive on fish or QFPCR for trisomy 21, would you actually, the patients want to terminate? Would you tell them to go ahead and terminate, or would you wait for something else?
I think the international guideline says you need to back it up with the karyotype previously, but now with the microarray maybe. That's the sort of
recommendation, isn't it?
Guidelines, yeah.
Yeah, so I mean that's what we say, but a lot of times they say microarray will take another 2 to 3 weeks. Why should I be waiting when I know? So no, I mean, hand on heart, do we all do wait for the microarray to come before the patients decide to terminate?
So I think it's the clinical scenario. So if I have a lot of soft markers and my NIPT was already positive and the gestational age is approaching 20 odd weeks, she's a previous cesarean, a lot of patients do terminate. But we do put in a note there that we would prefer that you wait for the second test.
Absolutely. Yeah. So very important point is to document. Yes, can I have any more inputs from others?
I think that kind of an individualized approach is very much pragmatic, because a lot of times by the time these reports come, patient is already 20, 21 weeks. And a chromosomal microarray or your backup test might take another thing. So although the recommendations say it should not be used as a standalone test, but clinically, I think we need to be more pragmatic and see the overall clinical scenario and decide. And if you have a lot of markers and obvious findings on the ultrasound, then of course we do go ahead and terminate based on a QFPCR.
No, but the point is, if you have abnormal ultrasound findings, you are not going to be doing a QFPCR in the first place, isn't it? You are going to be doing a CMA.
Yes. But the QFPCR is always kind of done as a first line test, and then for all CMAs, So even if you ordered a CMA, our lab would always process a QFPCR and a CMA together.
Right. Okay. So, right. And so we go on to our next case. This is a lady who came in at 27 weeks. She had a normal anatomy scan. And Dr. One second. Yeah. Polyhydramnios, and we have a double bubble sign. So Dr. Jyotsna, I mean, she's come back to you and, discomfort. What is your counseling at this point?
I would like to first look up for another anomalies.
Yeah, so
The
another
other,
point to add is that she had a low risk on combined FTS and no other high risk factors.
yeah,
Yeah.
she had no previous risk factor, and now this is a late anomaly which has come up. And intestinal anomalies do come up after 24 weeks only. So whenever we are doing a third trimester scan, we have to specially look up for all these things. And in this case, when this has come up, we will look for an associated anomalies in other organs. We will look up towards the heart. We will assess the degree of polyhydramnios, and we will again reconsider our invasive testing option to rule out Down syndrome, as 30% of the fetuses with duodenal atresia have Downs.
So, which means that even if it was isolated, would you go ahead and recommend amniocentesis at this point? And generally, I want your opinion about late, as Dr. Anita was saying, or Dr. Sangeeta was saying, rather Pragya was saying about doing interventions at this late in the third trimester.
See, if it is isolated, yes, I will still do it, because prognosis can be better told to the patient if we know the genetic result of the fetus accurately.
Absolutely, yeah.
And it helps the patient to decide for further management. Because
Right.
see, if it is a Downs, we will not go in for conservative management, send it to a pediatric surgeon, or look up for surgical options. And if it is chromosomally normal fetus, we might counsel towards a conservative and a
What
safe
test would you go in for here?
amniocentesis.
No, which test? Amniocentesis, you'll send the sample for which test?
We will do a QFPCR.
Okay, so here, okay, I'll just come back to you on that. So late diagnosis, we've said. Dr. Gina, you can take this. This is a lady who came for her first trimester screen, and we found, we did a transvaginal scan as well. And this is, what do you think the scan findings are, and what would you recommend here? Gina, you can take that up as well, yeah. Dr. Gina, you there? Dr. Manisha, you can also take that up.
Okay, so what we are finding here can we go? Yeah, so what we are finding here basically is a very typical 3-vessel trachea view, where you find that the aortic arch is on the right side of the trachea with the left-sided ductus arteriosus forming a U configuration.
Yeah.
With trachea in the center. So basically it's a right-sided aortic arch. So we
Right.
would also look for 3 to 5% of these are also associated with D. George's. So we would also look for other features of D. George's like thymic hypoplasia. Might be difficult to make at this stage, but yes, testing. If we are very sure of the diagnosis, which is quite clear on these scans with the transvaginal sonography, almost confidently we can diagnose. I think I would offer her a test right now. Which test? Fish for microdeletions, especially looking for 22q11 microdeletion.
Right. So that's what I was aiming for, that this lady had a fish and it came back as 22q1, which my, fellow had done it. And so it's typically for the previous case and this case, we know what we are looking for. So that is why fish is fine here. And, we can just tell them what the, we can look at the specific test, that is 22q11 deletion, or trisomy 21 we're looking at. We can do that, and then we can have the diagnosis quickly. So Dr. Vandana, here again, we need you. So she's come in. What would be the advice? Do these patients who have right aortic arch need any testing of the parents at all, or it's okay to just come back in the next pregnancy?
Yeah, so the 22q microdeletion is present in this fetus, and it could have come de novo, which is more likely. And it is also possible that it has come from one of the parents, like that is less than 10% chance that, or 10 odd percent that it's come from one of the parents, because it's an autosomal dominant condition. So autosomal dominant conditions, if the parents are unaffected, are usually because of the de novo mutation which has happened. I think over the years, only one family I remember where one of the parents was affected. Otherwise, most of the 22q that we see don't are just de novo.
Yeah.
So
okay,
we can check the parents for the 22q. I think another point I like to make is, I think my test of choice for detection of 22q microdeletion would be a microarray and not a fish per se. You might miss some breakpoint. So if I think the geneticist could.
Yeah, Dr. Shashwati, Veronica can chip in as well. Yeah.
Yes, I fully agree with her. Though it is looking like the most commonly it is digeorge, but we have to keep in mind that the other microdeletion, we should not miss any other things. Also, I want to make a point is that if there, as she has said rightly, that 10% of the cases are inherited. So if we do get a parental, microdeletion present in one of the parents, then our counseling will be that in the next pregnancy, there is a 50% recurrence risk. So for the next pregnancy, definitely we should go for prenatal testing to see whether it is inherited again in the next.
Right. So that's something, so we would, so even if it is barn door right aortic arch, you would recommend a CMA over a fish. Is what?
Yes.
Right. Okay. Thank you so much. So just quickly going on to the next case before Veronica takes over. This lady came in, had a, I don't have, she came in at an anomaly scan which showed a unilateral cleft lip with small muscular VSD. I don't have the clips here. Dr. Vinayak, what would you offer here? Now she has an anomaly, well, it's a repairable, but it's a small muscular VSD. We have two anomalies here.
Yes. So, ma'am, in isolation, unilateral cleft lip is not associated with chromosomal abnormalities, but since there are multiple abnormalities and muscular VSD is associated with chromosomal abnormalities, I'll ask for a karyotyping and proceed with the array also. So microarray and karyotype, both the reports I'll ask for in this patient.
Absolutely. So just quickly going on to that, the dictum is very clear that if you have anomalies, please do not go in for a QF-PCR or karyotype. You have to go in straight for a chromosomal microarray. And here this fetus had a deletion of 1p36, and so obviously the fetus was terminated, which was not diagnosed on karyotyping. It was only on chromosomal microarray. So Dr. Shashwati, what is the interpretation of the above report? What is the significance? And again, is the parental testing required for reproductive counseling?
Yes, here this looks, there's a loss of chromosome 1. There's some amount of loss in chromosome 1, and there is a gain in chromosome 9. So possibly we are looking at, unbalanced, we are looking at unbalanced deletion and duplication. So possibly in this case, there was a balanced translocation of 1 and 9 in the parents, one of the parents. So in the fetus, it has come out as unbalanced. So again, the balanced translocation, if we are finding it in one of the parents, we have to counsel them that there is a chance recurrence risk of 33% again in the next pregnancy. So again, prenatal testing for the next pregnancy must be done.
Right.
Yeah. Dr. Sita, I would just like to mention one point here. In this case, why are we doing a karyotype? I think my first line of choice of investigation would be a microarray rather than a karyotype.
Yeah, absolutely. So that is why I put it up here that this was they had done a karyotype, which was not the case, which was not to be done, because clearly now the dictum is that with any sort of anomalies, please go directly for a microarray and not doing any other test. That was what I was trying to tell, because this is not what we should be doing. Yeah. So that's what here it is, that CMA identifies all the abnormalities detected, plus it may identify additional abnormalities, especially when you have a fetus. A diagnostic yield increases. We know by this seminal paper that 6 to 13% increase yield of CMA, and even when there is no abnormality, 1 to 2%. So the recommendation is directly go in for a CMA and no any other test. So I'll move on to Veronica to take over. Veronica, Dr. Jyotsna and Dr. Gina, you're there?
Yeah, I'm there.
Okay, sorry. Okay, yeah, Veronica, go on. Yeah.
Yes, ma'am. Thank you. So we've discussed about chromosomal genetic testing, and we know that chromosomal microarray is the first tier test for multiple malformation, for early onset fetal growth restriction, for increased nuchal translucency. But what beyond microarray? And also, all the microarray must be coupled with a rapid aneuploidy technique. So QF-PCR and microarray are not two optional tests. They are additive to each other, and they must be performed in addition to each other. Also, QF-PCR has an additional value of detecting maternal cell contamination. So when we want to look at maternal cell contamination, especially in our CV sample, it is a great idea to do a QF-PCR along with microarray more than we do in amnio. So now we'll move on to certain cases where we highlight the role of single gene testing and when we need to do that. So this is a pregnancy of 22 weeks of gestation with enlarged cystic kidneys and echogenic kidneys with bilaterally associated which bilateral cysts and associated oligohydramnios. The previous pregnancy was similarly affected. Ma'am, next slide, please. So Dr. Gina, you can see the USG here. So I think I already described the USG. So once you see these abnormalities, what are the other abnormalities do you want to look at, or any, do you want to do the ultrasound in parents also?
Okay, so when we see large enlarged hyperechoic kidneys, so the first thing we think about are the ciliopathies. So the ciliopathies basically are the polycystic kidney disease, that is the autosomal dominant and recessive, the ARPKD and the ADPKD. And also we need to look at, we need to consider Meckel-Gruber and Juberts and Bardet Biedl. So we have to look at those associated findings to come to a definite, a probable diagnosis. Like in case of Meckel-Gruber, you've got to look at the CNS to look for any encephalocele, or even in Juberts, you look at the molar tooth sign, or in ARPKD, you look at the liver. And also such kidneys can also be found in infections. So we look for other signs of infection in the fetus. And like in the brain, we can look for ventriculomegaly or but basically, yes, these look more like, considering that there's a lot of oligohydramnios, it is said that it is more common like in the autosomal recessive variety, though it can be found in the autosomal dominant as well. So we have to look at the parents also to look if there are any, polycystic kidneys in the parents, because the autosomal dominant one basically manifests more in the 4th to 5th decades of life. Yeah.
Thank you, Dr. Gina. So we have a group of disorders called ciliopathy. That is one group, the commonest, out of which definitely the APK.
Hello, Veronica? Hello?
But these additional tests.
We are not able to hear you, Dr. Veronica.
Veronica? Hello?
She here?
Can you switch off your video if it's on? Because your voice was breaking. Veronica, you there? Hello? Is Veronica there, or she got disconnected? I can't see her.
Ma'am?
Yeah.
Ma'am, so actually I see the screen. Okay. Krishna, you this question?
Shall I address the next question? I'm
Yeah,
not
yeah,
able to hear you properly.
Yeah.
So if we have a 22-week fetus who's having severe oligohydramnios with large kidneys looking like this, we really know what the prognosis is. So keeping this prognosis into mind, we have to also look for finding out the reason why this happened. So chromosomal analysis in the terms of sequencing might also be required. The practical question here would be, how do we take out the amniotic fluid when it is severe oligohydramnios? So keeping all these points into our counseling, we have to counsel that the kidneys are looking bad. The AFI is very low, giving another point towards bad prognosis. And yes, because this is the second child which is affected, we have to definitely reach for a genetic diagnosis so that we can evaluate a recurrence risk for this pregnancy. And also, we would like to do a pedigree to see whether the previous generations anybody was affected here or not.
So, Dr. Jyotsna, you can see the pedigree here, and the pedigree clearly shows that there are multiple affected family
Yeah,
members.
so it looks like an autosomal dominant.
Yeah, but there are also you can see that the affection of the fetus is very early. So basically, the inheritance
That, yeah,
pattern here
is
is a
not
little
very
bit
definitive.
different,
Yes,
but
definitely. So
yeah.
there might be some compound heterozygote type situation here. We don't know the gender.
Not compound heterozygote really, but maybe there are two dominant genes
Yeah,
that are causing
genes
this.
which might be, yeah, they might be compound.
Okay, thank you. So, Dr. Saraswati, I think we just discussed this, but anything you want
Yes,
to add?
yes,
What information do
yes.
we gather from this?
Yes, from here, actually, can we go back to that previous slide?
Sure.
The pedigree slide, yes. So you see, every generation is having an affected member. That is one. Second is one of the parents are affected, and in case of autosomal dominant, this is the scenario. One of the parents will be affected, and also this is a here. Though it is found, I mean, autosomal dominant PKD is not usually found in the cyst zone appear in the fetal life, but we have to keep in mind that ADPKD is the pedigree showing ADPKD, and as Veronica rightly pointed out, this can be, we are looking at two different genes causing the cystic kidneys.
So, Dr. Saraswati, you can also see from this pedigree that, ma'am, can you go back, please? Sorry. So, this person here was also affected. The grandfather is also affected, but the son here is not affected. So, important thing to remember in some genetic disorder is the age-related penetrance. So, a lot of times in milder genes, we don't have a phenotype at a certain age. So, maybe he has a milder ADPKD because the grandfather did have ADPKD. So there is actually inheritance coming from both the sides. So also characteristic of autosomal dominant condition is a skipped generation due to the penetrance which may be low in some conditions. Okay.
Okay. So yeah.
So Dr. Manisha, how do you evaluate such a patient, and what will be the causes of these presentations?
So based on the ultrasound findings, we are basically looking at either a diagnosis of ADPKD or ARPKD. Now, as we said, both the kidneys have failed and there is no amniotic fluid. So one thing, we definitely need fetal testing here. So one thing that can be done here is probably do a cordocentesis, which might be technically much easier to do a cord blood sampling and send it for a whole exome sequencing. Apart from that, we need to evaluate, do an ultrasound KUB of both the parents to see to see if the parents are affected, because ADPKD, as we know, presents late. And of course, we have told them guarded prognosis. So we offer them termination of pregnancy. And once the pregnancy is terminated, I would also like to do a fetal autopsy to confirm our diagnosis, to look for cysts anywhere else in the body, look for any associated findings. So that would be my evaluation for this patient.
Thank you, ma'am. So, Dr. Vinayak, what is the next step after there was persistence of bilateral cysts as 23 weeks? Would you like to offer a discontinuation and a postnatal examination?
Yes, ma'am. Since the lacquer has become nil before 24 weeks, the chances of pulmonary hyperplasia is very high and the prognosis is very poor. So it asks the patient not to continue the pregnancy. And if in the unfortunate event the pregnancy is terminated, I would definitely offer the fetal autopsy so that we can correlate our ultrasound and genetic findings along with the autopsy findings.
Absolutely.
So I
Thank you.
think that will
Because
be the best course of action in this way.
yeah, because a lot of times we get these variants called variants of uncertain significance in the genetic report. So this autopsy is very useful in those cases. So the pregnancy was in fact discontinued, and this is what the findings looked like. We can see bilaterally enlarged kidneys and the kidney microscopy with large diameter variable cysts in all parts of the nephron, including the glomeruli. Next slide, please. Dr. Vandana, ma'am, would you like to recommend any genetic testing? Do you want to do it before or after discontinuation? This question also often arises. And which testing would you like to do and why?
So here, since we have a condition which has come from the parents, I think the trio testing would be preferable. So we would like to go for the exome for the fetus as well as both the parents. And the targeted genes being autosomal dominant, polycystic kidney disease. So we know those are on the, I think the 4th and the 16th, the common ones. In fact, I remember, Veronica, long back when there was no exome, and this is 2005 or 6, I had a classical polycystic kidney disease, and there were rhabdomyomas in there. So it was like a continuum gene syndrome where a big block was missing. So the fetus presented with PCKD, ADPCKD like features with rhabdomyomas also. So, but that it was all guesswork on our part because there was no genome backup testing. But now we can go for the sequencing for the trio.
Yes,
And I think it's a DNA-based test. So if you don't get samples prenatally, you can still comfortably get your samples postnatally. If you have a nice fetal sample postnatal, that should also work.
Absolutely, ma'am. But there was no liker, so more of a reason to maybe discontinue and then do the testing as well.
I think, yeah, so we can take the cord blood or even after birth, yeah.
So exome sequencing in this case, because we already know that echogenic kidneys or bilateral cystic kidneys are not caused due to chromosomal disorders. So there are certain malformations where we directly perform exome sequencing, like skeletal dysplasia and like polycystic kidney disease. So this was the report. And as I was discussing, in the fetus, we had two genes, and both were genes which cause autosomal dominant polycystic kidney. So we had from one side, from the maternal side, we had a PKD1 gene, and from the paternal side, we had the PKD2 gene. So because PKD2 gene is milder, so that's why we did not have a phenotype in the father. Because in this person, so in the fetus, there are both PKD1 and PKD2. So this is like a doubly dominant disorder, and that's why more severe instead of a recessive disorder. So that's trio sequencing is a great way to elicit such disorders, especially when you're performing a test antenatally to get quicker results. Next slide. So now I think we've discussed this.
Just give an example for the audience. So if you have autosomal dominant achondroplasia, and if both the parents are having and the baby inherits achondroplasia gene from the mother and the father, it may present as a lethal early onset skeletal dysplasia rather than a late onset achondroplasia. So it's similar kind of.
So genetics is really interesting.
Family.
So there are very few pure dominant disorders. That means that the disorders which will present in the same way if they are heterozygous or homozygous, most of these disorders are called semi-dominant. That is that they will be more severe when they are found in the homozygous state. Next slide. So this is just the this is a Sanger report here. So if you have done a solo sequencing instead of a trio exome sequencing, then you can just go back and test for the targeted variants in parents. So it will just save some costs. It is more useful in a postnatal scenario because then we have enough time to do these tests. For an antenatal scenario, trio exome sequencing is definitely a better. So, Dr. Jyotsna, ma'am, what are the reproductive options for the next pregnancy?
So, since we know that the inheritance is there and it is a dominant type inheritance and the chances of fetal infection are high, so we will give her options of either going with her self-conception and doing a CVS, or we can change the gamete, ask her to go for IVF with donor gametes, or we will do a pre-implantation genetic testing for the monogenic disorders, where she goes in with her own gametes, but before the embryo is implanted, we take a biopsy and do the genetic testing for the embryo.
Thank you, ma'am. That's great. Thank you. Next slide, please. So, this is, we're moving on to the next and final case of the panel. This is 27-year-old female. The marriage was non-consanguineous, conceived naturally, and the first trimester screen was low risk for aneuploidies. In the scan here, though NT is not taken really well, but there was an increased NT. They did not want to do an invasive testing at that time. Ma'am, can you, I think there's an animation. So, Dr. Vinayak, would you like to describe the ultrasound and what should be the next step? And how do you classify ventriculomegaly?
So, ma'am, in this second ultrasound picture, we can see it's a enlarged cisterna magna. Posterior fossa is enlarged. Both the cerebellum appears to be small, and the vermis could not be seen. But based on this photo, I will not comment whether the vermis is absent or not, or whether the vermis is hypoplastic or not. And there is bilateral ventriculomegaly on both of these images C and D. So my next step would be that I would try to go for a detailed neurosonography, especially in transvaginal route, to go for TVS neurosonography and to see whether all the structures, CSP, fissures are all okay or not. And ventriculomegaly is described, ma'am, it's mild, 11 to 12 millimeter, 12 to 15 is moderate, and more than 15 is classified as severe.
Thank you. So, Dr. Gina, what are the differential diagnoses in this condition? And what is the role of fetal MRI? And maybe if you can give us just a quick one-liner about fetal MRI versus a neurosonogram.
So, fetal neurosonogram, I mean, whenever we see any abnormality like a ventriculomegaly, in fact, this one had colpocephaly, that intracranial translucency was also increased in its in the 13-week, I mean, NT scan, which was suggestive of a posterior fossa malformation even at that stage. But then ventriculomegaly, it can be because of some cortical, developmental malformation, firstly. So it's because of some cortical development or because of some Dandy Walker or schizencephaly, megaloencephaly, and polymicrogyria. So then it can also be because of obstructive causes like aqueductal stenosis, or it can be because of infections, chromosomal, and there's different various anomalies. So basically, fetal MRI, it has a role of, because a lot of, even in a detailed neurosonogram, sometimes we might not be able to find a lot of additional anomalies which are causing the ventriculomegaly, especially like these cortical developments. And so, and especially if the mother is, if she has a high BMI, or, it is the head is not low down and we can't do a proper fetal neurosonogram. So MRI definitely scores in detecting a lot of additional anomalies which are causing the abnormality. And we do it after 24 weeks because it not only detects these various sulcation gyration anomalies, but it can also detect hemorrhage, which can also be a cause of, ventriculomegaly. So yes, MRI, we should just remember that we should do it after 24 weeks because it gives a better answer. Yeah.
Thank you, ma'am. So, Dr. Manisha, how do you evaluate fetal ventriculomegaly?
Okay. So first we have done, we need to do a detailed ultrasound scan. So we have found out that there is severe ventriculomegaly. So we do a detailed, so we look for any other cardiac anomalies, extra CNS anomalies in the detailed scan. Then we go for a detailed neurosonogram. So detailed neurosonogram done best transvaginally, but as Dr. Correctly pointed out, that if the baby is in breech position or the woman has high BMI, then we might not be able to do an optimal neurosonogram, in which case you might have to resort to an MRI. So MRI, especially if you're thinking of cortical malformations and other things as the cause for ventriculomegaly, then it will really help. In terms of evaluating this, now causes, as we said, chromosomal infection, single gene disorders, anything could be the cause of ventriculomegaly. So we would like to do an invasive testing here in the form of amniocentesis, send the sample for a chromosomal microarray, DNA banking, and do a PCR for toxo plus CMV. If it is not available PCR, CMV, we can even do maternal serology testing for CMV and toxo.
Thank you so much for the elaborate answer. Dr. Jyotsna, how would you like to counsel this family at this stage? For which for testing or discontinuation? You're not audible. You're on mute, Dr.
Yeah, sorry. At this age, with these images available, the fetus looks like having severe ventriculomegaly. So the amount of ventriculomegaly gives us the most important information which we need to put it forward towards the patient for counseling. Then the second part would be the genetic analysis and a detailed neurosonogram and the associated anomalies which would have come up whether as positive or negative in our workup which we had done previously, as Dr. Manisha had said. So if we have associated anomalies, if we have severe ventriculomegaly, if we have something coming up in genetics, we have to definitely take up the hard decision and ask for termination. Even without doing all these, this is a classical case where the patient can opt directly for termination. But definitely we have to tell that we need to know the cause of this so that we can avoid the recurrence for this.
Thank you, ma'am. So basically we prognosticate, and if they would like to discontinue, it's up to them. So they did opt for termination with a postnatal examination. And this is how the autopsy looked like. So just to bring in that a fetal autopsy is a part of the genetic tests as well, because it just gives us so much more information. So ma'am, because there is the dysmorphic features are animated, so if you can just go to the
sorry.
Vandana ma'am, would you like to just highlight?
So at the it's when you look at this baby, you feel the eyes look smaller, and there is I can't see the ears very well, but the chin also looks little small, and the philtrum is bigger. So those are the facial features, but with the brain findings there, one starts thinking immediately in terms of what is classically a Walker-Warburg syndrome.
Next slide, please, ma'am. Ma'am, will you like to continue to describe?
Yeah, so this, if you look at the brain here, you can see the severe hydrocephalus and the dilated ventricles and the cerebellar hypoplasia with the agenesis of the corpus callosum. It's all pointed out there very neatly. And also, if do you have more sections of the eye, or this is it? All right. So we can also look for Leisen-Kefli histopathologically.
Yes. So ma'am, we did the histopathology, and the histopathology, as you said, showed disorganized layers of the cerebral and the cerebellar cortex. So, and there was also hypoplasia of the cerebellum. The cerebellum was small and aplastic vermis.
Okay, so all of those features are highly like they're going in favor of what we commonly see as Walker-Warburg syndrome. And those conditions usually are autosomal recessive. Mostly they're due to the gene in POMT1, POMT2. So did you do genetic testing here? Or?
Yes. So ma'am, we'll go to the next slide, please. So, Dr. Gina, which genetic tests would you like to do? Dr. Saswati, Dr. Gina.
Here, it is better to go for exome sequencing.
Right. And any reason for that?
Because we have got a provisional diagnosis of Walker-Warburg syndrome, and the genes involved, usually there is sequence variations, and not very commonly the deletion.
Thank you, Dr. Saraswati. Dr. Manisha, we did the genetic test and CMA was normal. I think you just mentioned that exome sequencing we'd like to do. So you agree?
Yes.
Okay.
Yes. Yeah.
So this is the report of the test called whole exome sequencing, which is also known as exome sequencing. And this is something we should order for fetuses because we do not have a very good phenotype normally. So anyone can take this question to interpret the interpretation of this report. Vandana ma'am?
Yeah, so this report shows that the baby is got an autosomal recessive homozygous condition, meaning both the alleles are having an abnormal mutation. And so the baby has a pathogenic autosomal recessive homozygous condition, probably one allele from each of the parents. So the parents most likely are carriers of the same. And one would expect a 25% recurrence risk in a future pregnancy for this.
Thank you. Thank you. Next slide, please.
Yeah.
Yes,
This
the report has been already interpreted. Only one thing I would like to know is whether there was any consanguinity in the parents,
no, it was non-consanguineous.
non-consanguineous. So,
Unlucky.
yes.
So these are the POMT1 related allelic disorders. So the disorders which are caused due to a single gene are known as allelic disorders. And this is then up to us to decide that which disorder does our patient fit best into. So we have a muscular dystrophy phenotype, which is a little later onset. We also have the congenital onset, which is known as Walker-Warburg syndrome. And we have an LGMD phenotype, which is quite late in onset. So according to this, our fetus will have the congenital onset with brain-eye anomalies. Next slide, please. So when we have a phenotype, we can go back to this really interesting and useful site called OMIM and put our gene and look at the phenotype that is mentioned. And then we can correlate and do a reverse phenotyping with our patient as well.
Yeah, so we already discussed this, that it's an
Yes.
autosomal recessive, yeah.
This one we've discussed the recurrence 25%, and the different genetic counseling remains the same in the recessive disorders, and it is different for the dominant disorders. But in that case, we had two dominant disorders. So actually, the risk of recurrence in the polycystic kidney case was 75%. So extremely high. Here we have a 25 risk of recurrence, and similar options can be given.
Yeah. So this is just one study where they've said that, in 8.5% of pregnancies you can offer exome. So I think that's the way forward nowadays, isn't it? Yeah. Right. So we just end the panel and just one line from each panelist about genetic testing and which one. We should start with Dr. Jyotsna.
The better the better we are at scan, the better we are at picking up the genetic diagnosis, making a genetic diagnosis and ordering for a proper test. So scan plays a vital role, very important role. I think the first encounter.
Right. Thank you. Dr. Manisha.
I think a detailed family history and a proper workup is of key importance here. Then that gives you a lot of insight, history of consanguinity, family history, and all that is very, very important when you're dealing with a genetic disorder.
Right. Thank you. Dr. Vinayak, what about you? Your message? Hello?
Ma'am, maybe he's not here.
Yeah. Okay,
Yeah.
Dr. Vandana.
Yeah, so I think universal screenings for certain common genetic disorders, like for example, thalassemia, which could be done preferably in the pre-conception setting. That would be the way forward, I think, for couple carrier screening maybe, or thalassemia screening in pre-conception clinics.
Absolutely. Dr. Gina, your message?
Actually, in my practice, whenever, I come from Assam and, not all people, or not all patients will be willing to first go for a very expensive test. So sometimes, whenever, suppose there's a hydrops or anything, I always go for that CMA. But then I always, try to counsel the patients for doing a DNA storage because I tell them that it's only 1,500, but then, so that sometimes there have been patients where CMA has been negative and other tests have been negative, and it is only by doing a whole exome sequencing that, we've come to a diagnosis. So
Absolutely.
yes, I try to advise the patients, for DNA storage, even when they are not willing for a whole exome sequencing in the beginning. I mean,
Ab-
single gene, when you are absolutely certain that it's going to be a single gene, we try to convince that it's going to be, you go for a whole exome, but then, when you're not sure and we just go for a CMA, then I try to advise for a DNA storage so that, they get answers later on.
Yeah. Thank you. Shashwati?
Actually, in my practice, I have seen a lot of patients having, VOUS is coming up in a big way because very rapidly people are asking for whole exome sequencing, getting a VOUS, and not being able to understand what next to do. So I think if there is a proband in the family, the testing should be done for the proband. If there is a VOUS, all this must be done preconceptionally for the next pregnancy. So the VOUS of the proband has to be done, family segregation, but parental segregation should be done next to find out or reclassify. Once we get the variant, then we should ask them to go for the next, planning the next pregnancy. Because many times we are running against time. There is a proband, we haven't got the genetic diagnosis, or we have got a VOUS. So in that case, trio testing in case of the fetus and the parents, it really doesn't work because that time we are fighting against time. So, trio testing, if there is a proband in the family, should be done previous to the planning, previous to the next pregnancy.
Yeah.
I think, I don't know whether I was a little confusing. But the trio testing should be done before planning for the next child.
True. And Veronica, your comments on the latest on the block, the low pass genome sequencing.
Yes, ma'am. So, low pass genome sequencing is a new excellent technology. It really sequences the whole of the genome, not just the exome, the whole genome, but the number of reads it does, that is, the depth is low, so the cost is low. So, it is a better form of a low density microarray. It will pick up everything that your low density microarray picks up, and the cost is a little lower than that. So this low pass genome is sequencing the whole of the genome and picking up deletions, duplications. So it is not an alternative to genome sequencing. It is actually an alternative to either your qFPCR, your FISH, or your low density microarray. The indication as of now for whole low pass genome sequencing is your POC in a recurrent pregnancy loss, or when your POC is lost early in pregnancy due to other reasons. So on that test, on that POC, we can perform the LPGS test.
Yeah. So that's, I think we've ended on that. And if anybody else wants to add anything, otherwise.
Ma'am, actually, in my sorry, ma'am, at that time I had some network issues.
Sure.
So it's a few cases, POC samples I had sent for microarray, which came back as negative. But since the low pass genome has come, all the POC samples that I have sent have come back. They have been able to do the test, regardless how bad the fetal tissue was. So
sequencing based tests are actually easier to do than array based tests. So that's why.
So seeing that also, I have changed my amniocentesis. A few of my amniocentesis clients who cannot afford the microarray, I'm giving them the options of low pass genome also.
Especially when you have anomalies in the fetus, I think the low pass genome sort of will work better, isn't it?
Yes, sir.
Yeah. So if you have an option. So there we end, and we've said that we need a detailed ultrasound, as Dr. Jyotsna said, we need to have the obstetricians, we need to liaise with them, we need to have the genetic, exactly know what we are doing. So prenatally, if we know the proband or the carrier status of the parents, and then if we find an abnormality in the fetus, it is better to look at what we're exactly trying to find out, rather than putting a needle in the haystack. So we have a proper phenotype, and then once the fetus is born, we have a proper autopsy, and we do, do the test on the fetus. And minimum, the requirement, if they can't afford any expensive tests, the minimum is the DNA storage. But please do not lose information on the fetus, because once they go on to the next pregnancy, we don't have much to offer them if we don't have had the previous information. So thank you so much. And if there are any questions in the chat box, we can sort of take it up. Prasanna is left, so yeah.
Yes, I'm there. I'm there.
Yeah. Are there any questions for the panel, or that's fine then? We'll just close it.
No, there's nothing.
All right. Okay. So thank you all. And Veronica, any concluding remarks from you?
No, thank you so much, ma'am. I think it was extremely interesting and interacting with everyone. Thank you so much.
Thank you, panelists, for
I
all
must
your.
congratulate both of you for the very, I really enjoyed the panel.
So there's one more question, I think, just come up. When can we offer low-pass genome sequencing and prenatal aneuploidy test pan-NGS? So Veronica, give it to you.
Pan-NGS, I am like hearing this for the first time.
Yes, that's why I said Veronica, on to you.
So, low-pass genome sequencing, I think we just discussed. So, we need to understand the concept. So, low-pass genome sequencing is going to detect a little bit larger deletion duplication than our high-density microarray will. So, it will miss the smaller deletion duplications. So, we can order it in a case where we have a severe abnormality, a severe anomaly, or a lethal condition, like in a product of conception. It is by no means replacing your exome sequencing, because it is not supposed to be testing your sequence variants. It's for copy number variations. Maybe it is now going to replace our microarray once it becomes even better, but not exome sequence.
Yeah, so that's the basic mistake people make, that they say it's an alternative to exome rather than, because the name sounds. So I think we should
Sounds
try.
like
Yeah, sound the name as well. So thank you all and good night, and we meet again for the next Fetal Vision webinar after a month.
Thank you so much.
Thank you. Thank you, Dr. Tina, Dr.
Thank you, ma'am.
Vandana.
Thank you.
Thank you. Thank you, everyone. Thank you, everyone, for your time.
Thank you, Sita, for involving. Thank you, Prasanna, for the convening and the.
Thank you.
Thank you.
Manisha, hi.
Recording stopped.
Okay, see you all. Good night then, and we meet again.